wrap the fundus of the stomach around the lower esophageal sphincter. And this is called as Nissen's fundoplication. It is a complete wrap or a partial wrap. So we know it is a complete 360-degree wrap. So complete 360-degree wrap beta around the lower esophagus is known as Nissen's fundoplication. That is the surgery of choice. Nissen's fundoplication is surgery of choice in two conditions. One is GERD. Second is hiatal hernia. So GERD and hiatal hernia are the two conditions jahan pe Nissen's fundoplication is the surgery of choice beta. Important. 360-degree complete fundoplication is Nissen's. Anterior 180-degree fundoplication is DORS. Anterior 180-degree fundoplication is DORS fundoplication. Posterior 270-degree fundoplication is Taupets. So posterior 270 degrees Taupets fundoplication. That is important. Shabash. जिन्होंने मैनोमेट्री बोला बेटा इट इज नॉट अ डायग्नोसिस ऑफ मोटिलिटी डिसऑर्डर लाइक अकलेजिया कार्डिया. Achalasia cardia mein patient has dysphagia as the main symptom beta which is not present over here. Barium swallow is again the first line investigation to be done when patient presents to you with dysphagia. यहाँ पे there is no dysphagia beta, so no barium swallow will be done. Understood? This is the management in cases of GERD. Now next important if I talk about is nothing else but foreign body ingestion. Important topic from ENT as well as surgery beta. Foreign body ingestion की अगर मैं बात करूँ तो we know here the most common age group which will have a foreign body ingestion will be children, and the most common foreign body ingested by children will be one is coins and second are peanuts. So coins and peanuts definitely beta are the most common foreign bodies ingested by children beta. What is the most common foreign body ingested by adults? We know adults में the most common foreign body ingested is the fish bone, and elderly patient में the most common foreign body is the dentures or the loose teeth. The loose teeth or dentures are the most common foreign body in elderly patient. Now, the foreign beta can be anywhere beta. It could be in the patient's airway, that is larynx, trachea or bronchi, or it could be in the patient's GI tract, that is esophagus beta. Whenever a patient comes to you with foreign body ingestion, majority patients will be completely symptomatic or asymptomatic. So a lot of patients will be completely asymptomatic beta. Some patients may have symptoms and they will come to you like this. What is this? So some patients will have a choking sensation beta. Some patients may also have difficulty in breathing. That is dyspnea. Some patients may have difficulty in swallowing. Dysphagia. So choking, dyspnea, dysphagia like symptoms can be seen in the patients as well beta at times. So that is important. Whenever a patient of foreign body ingestion comes to you, first line investigation is X-ray. The first line investigation to be done in patients of foreign body ingestion is X-ray. X-ray has to be done or taken in two views beta. First is the AP, that is antero-posterior view, and second is the lateral view. Now, when the foreign body is in the trachea beta, so please tell me definitely on the AP view, it will appear slit-like or circular? Slit-like, and then lateral view it will appear circular. Next, when the foreign body is in the esophagus, then on AP view it will appear circular, and on lateral view it will appear slit-like. So yaad rakhna definitely. If I say beta that the foreign body appears slit-like on the AP view and circular or N face on the lateral view, that means the location of foreign body is in the trachea. If I say vice versa, that is on AP view, if the foreign body appears circular and on lateral view, the foreign body appears slit-like, that means the location of foreign body is in the esophagus. Now, another way to identify, I have told you, beta, in front of the foreign body, if you are able to see a black air column, that is a tracheal column. So we know that the foreign body is behind the trachea, that means inside the esophagus. Important. If the foreign body is in the esophagus, then the treatment is going to be different based on the location. Whether it is above the cricopharyngeal sphincter, that is C6, or below the cricopharyngeal sphincter, that is C6. So how do you differentiate? Very good. So if you're not able to count the number of cervical vertebra, better look for clavicle as the landmark beta. If the foreign body is touching any part of the clavicle, that means surely the foreign body has crossed the C6. ठीक है? तो अगर foreign body touch कर रही है clavicle को, तो that means it is surely below the C6. Clavicle यहाँ होता है, C6 यहाँ है. Clear? So that is important. So if I talk about beta the treatment in cases of foreign body which is present inside the airway beta, So if the foreign body is in the airway, then what will it do? So we know if the foreign body is in the airway, irrespective of the location, treatment is always an endoscopic removal. Okay, it could be laryngoscopic, tracheoscopic, or a bronchoscopic removal. Next, if the foreign body is in the esophagus, then we know we have to look for the location, whether it is above or below the C6. If the foreign body is above C6, that means it is large or small in size. Large in size, and that's the reason it is not able to cross. So above C6, agar foreign body hai, to it is large. So the treatment is an endoscopic removal, that is an esophagoscopic removal. But if the foreign body is below the C6 or below the cricopharyngeal sphincter, that means it is small. And if the foreign body is small, we know if the foreign body was able to cross the cricopharyngeal sphincter, which is the narrowest portion of the whole GIT, will it cross the whole GIT easily? Yes, then only go for observation and serial X-rays, beta. Observation and serial X-ray should be repeated to look at the movement of the foreign body. Along with that, you will ask the mother to give which kind of food to the child? Meshy foods to the child, beta, like dalia, bananas, okra, that is bindi, all of that. Okay? So that is important to be remembered. No issues with this. Next, if the foreign body ingested by the child, beta, is a disc battery or a button battery, treatment will be, if the disc battery or button battery is below the cricopharyngeal sphincter, treatment is very good. So please remember disc battery or button battery, beta, wherever it is present, okay, does not matter whatever is the location. Treatment is always an urgent endoscopic removal, beta. Okay, because we know disc battery is known to release alkali, and that alkali are known to cause liquefactive necrosis, increasing the risk of perforation. Important disc battery or button battery, beta, X-ray पे कैसे दिखेंगी? Which sign? On X-ray, disc battery or button battery will show you a double ring sign, beta, or oblique edges called as beveling. So double ring या beveling अगर दिखती है on X-ray, beta, that means the foreign body ingested by the child is nothing else but a disc or a button battery. Hopefully clear to all of you now. Chalo. If I talk about the next one, that is Sarkari question of your FMG exam, and that is achalasia cardia. What is the cause of achalasia cardia? So we know achalasia cardia is mainly what? Here, the lower esophageal sphincter fails to relax. So Elias does not relax at all. It stays in a contracted state, beta. So Elias fails to relax. What is the cause for Elias failure? Yes, so primary achalasia cardia is mainly due to absence of ganglionic cells or loss of ganglionic cells. In which plexus? So primary achalasia cardia happens due to loss of ganglionic cells. But in which plexus of the GIT? Meissner's or Orbach's? So please remember, beta, achalasia cardia happen due to loss of ganglionic cells in the Orbach's plexus of GIT, which is also known as the Mandrake plexus. Next important, if I talk about, it also happens, primary achalasia also happens due to deficiency of inhibitory neurotransmitters like nitric oxide and VIP. So even deficiency of nitric oxide and VIP are known causes of primary achalasia cardia. Secondary achalasia cardia is happening due to Chagas disease mainly, beta. Okay. Now, if they ask you in patients of achalasia cardia, there is a classical triad of presentation, beta. And those symptoms are first, as the lower esophagus is in a contracted state, beta, all the food collects in the upper part of the esophagus, and whenever patient lies down, there is regurgitation of food, beta. First thing. Second, that collected food releases a foul smell, that is bad breath known as halitosis. And third, obviously, if the ileus is contracted, patient is not able to swallow properly, and that is dysphagia. Dysphagia here, it is intermittent or continuous. In achalasia cardia, dysphagia is continuous. It is intermittent in a case of Zenker's diverticulum. That is how you differentiate, because achalasia and Zenker's will have these same three symptoms. The only difference is continuous dysphagia in achalasia and intermittent dysphagia in Zenker's diverticulum. One thing. Next important, dysphagia in achalasia is more to liquids or solids? So in achalasia cardia, the dysphagia is more to liquids because they are lighter in waste. They are not able to pass. Whereas dysphagia more to solids is a feature of Esophageal cancer, beta. That is important. Now, if they ask you about the investigation of choice, so first line investigation is a barium. Any patient coming to you with dysphagia, first line investigation is a barium swallow, but investigation of choice will be esophageal manometry. Why? Because if the LES is contracted, the pressure in the LES is going to be extremely high. And how much will be the pressure? 26 to 100 millimeters of mercury beta will be the pressure. Normal pressure is 8 to 25. Okay, so whenever the lower esophageal sphincter pressure is between 26 to 100 millimeters of mercury, that is a diagnosis of achalasia cardia. That is important. If they ask you beta on barium swallow when we do, which is the classical appearance that we are able to see. Yes, the classical appearance that we are able to see on a barium swallow is called as the bird beak appearance. It is also called as the pencil tip sign. It is also known as smooth tapering meta. Okay, if none of this is present, then last option would be rat tail. If smooth tapering is present, please prefer smooth tapering over rat tail. Smooth filling defect nahi, smooth tapering. Tapering का मतलब होता है narrowing. Smooth filling defect is a feature of. देखो आया ना? Smooth filling defect is a feature of benign esophageal tumor, that is esophageal leiomyoma. An irregular filling defect is a feature of esophageal cancer. Esophageal cancer on barium swallow shows you which sign? Rat tail appearance or a rat tail sign beta. Along with that irregular filling defect, important. And also shows which kind of appearance? Apple core appearance. Apple core appearance on barium swallow is seen in esophageal cancer. But apple core appearance on barium enema is a feature of colon cancer. That is important. Shabash. Now, if they ask you what is the treatment of choice, see, in achalasia cardia, obviously calcium channel blockers and balloon dilatation or poems like surgery can be tried. But treatment of choices, we know the treatment of choice for achalasia cardia is a Heller's myotomy surgery. Okay, so that is important. In Heller's myotomy surgery, there is a risk of GERD. So what should be a prophylactic surgery? Nescence or any other fundoplication. If they ask you what is a complication of achalasia cardia now, it will lead to increased risk of which esophageal cancer, squamous or adeno. So please remember, beta, achalasia cardia is a risk factor for squamous cell carcinoma of esophagus. GERD or Barrett's esophagus is a risk factor for adenocarcinoma of esophagus, beta. That is what is important to be remembered. Clear about? Next, another motility disorder where also the patient will come to you with dysphagia beta is this condition. अब मुझे ये बताओ in patients of DES or diffuse esophageal spasm, when the patient comes to us beta, how much will be the pressure on manometry? In DES or diffuse esophageal spasm, the pressure in the lower esophageal sphincter will be more than 120 millimeters of mercury beta. Important to be remembered is, in case of DES, the patient will not only have dysphagia, the patient will also complain of chest pain because of such a high pressure. Here, the whole esophagus is in a contracted state beta. And therefore, when I do a barium swallow for dysphagia in this patient, you are able to see a very classical corkscrew appearance. This corkscrew appearance is also known as rosary bead appearance. The corkscrew appearance is also known as rosary bead appearance, found in diffuse esophageal spasm. And treatment is nothing else but any myotomy surgery. So myotomy surgery is the treatment of choice for diffuse esophageal spasm. When the pressure on manometry is between 180 to 200 millimeters of mercury, the diagnosis is nutcracker esophagus. Pressure between 180 to 200 is the diagnosis of nutcracker esophagus. That is important. कोई दिक्कत motility disorders में? So that is what is important. Now, let's talk about another condition, beta, and that is here we are having a 30-year-old male, Kamlesh. ठीक है? Who is a chronic alcoholic beta, and the patient presents to the emergency room with chest pain along with retching episodes beta. What is retching? Patient oh, sorry, patient definitely has vomiting sensation but nothing comes out beta. Okay, he gives history of binge drinking earlier, that is drinking a lot of alcohol in a shorter duration of time. On palpation, crepitus is felt beta. When you palpate the chest, you are able to feel a crackling sensation, that is crepitus. This is suggestive of crepitus is suggestive of air below the skin, that is known as subcutaneous emphysema. And I hope all of you are quite aware about this classical triad where the patient will have chest pain, retching or vomiting episodes, and subcutaneous emphysema. It is a classical triad known as macular triad. And we know that whenever macular triad will be present or given in any case, it has to be a diagnosis of Boerhaave syndrome beta. मैकुलर स्ट्राइड जब भी दिया जाता है किसी भी केस में, it has to be a diagnosis of Boerhaave syndrome. Boerhaave syndrome is a case of esophageal tear or esophageal rupture. So we know that Boerhaave syndrome, which is there, beta, it is a diagnosis of esophageal rupture or a spontaneous esophageal perforation. Esophageal tear is known as Mallory-Weiss tear or a Mallory-Weiss syndrome. Clear? Mallory-Weiss tear may be the same history will be given. That means the patient is a chronic alcoholic beta, had a binge drinking episode. But now when the patient comes to the emergency, the patient only and only complains of hematemesis, that is blood in the vomitus. That's it. Okay? So binge drinking followed by vomiting and only hematemesis or upper GI bleed is a diagnosis of Mallory-Weiss tear, which is a partial tear in the esophageal wall. But after, a chronic alcoholic after a binge drinking episode with whole features of macular striatum beta has to be a diagnosis of Boerhaave syndrome or esophageal perforation. Important, in case of Boerhaave syndrome, as the air leaks out into the mediastinum, the patient will develop pneumomediastinum, and due to pneumomediastinum, there is a classical chest X-ray finding called as, we are able to see the classical continuous diaphragm sign beta. So this feature again will not be present in Mallory-Weiss. Continuous diaphragm sign will be present beta. Okay. In cases beta of Boerhaave syndrome, continuous diaphragm sign due to pneumomediastinum is visible on chest X-ray, but it cannot be confirmatory. So what is the investigation of choice for confirmatory diagnosis? Again, the investigation of choice is a CECT scan beta, that is a contrast enhanced CT scan or a CT with oral contrast definitely. If they ask you treatment, what is the first line management in Boerhaave syndrome? Very good. The first line management in a Boerhaave syndrome will be basic resuscitation, that is airway, breathing and circulation, because the patient can be hemodynamically unstable. This is the first line management. What is the definitive management? Exploratory ईसोफेगस के लिए abdomen खोल दोगे तो criminal negligence कहलाएगा ये. ठीक है, तो that is important. तो exploratory thoracotomy definitely beta to be done along with mediastinal lavage, because the patient is going to develop mediastinitis, so patient has to undergo mediastinal lavage. Plus minus repair. Plus minus repair का मतलब either early or a delayed repair. That depends on the time of presentation. ठीक है, तो exploratory laparotomy along with mediastinal lavage with an early or a delayed repair. That is what is done in Boerhaave syndrome. Done. Next important is this classical picture where a patient comes to you with dysphagia beta, and as the patient has come to us with dysphagia, we have performed a barium swallow. When we do a barium swallow of this patient, you are able to see this classical picture jahan pe the esophagus has been compressed from outside. Very good. It is a classical diagnosis of dysphagia lusoria. Now we know dysphagia lusoria mein there is an artery which compresses the esophagus from outside causing dysphagia. What is that artery? So this dysphagia lusoria happens due to a right normal or aberrant? It happens due to a right aberrant subclavian artery. So that right aberrant subclavian artery is known to cause compression of the esophagus from outside causing dysphagia lusoria. Next important is another condition. Again, patient presents to us with dysphagia. So we have performed a barium swallow. On that, you are able to see compression or narrowing in the esophagus beta due to a fibrotic ring in the esophageal wall called as Skadsky's ring. If I talk about Skadsky ring, we know it is a fibrotic mucosal or a submucosal ring in the esophagus. Important. Skadsky ring mein treatment of choice will be. Very good. Treatment of choice will be an endoscopic balloon dilatation. So you will take a balloon at the site of the fibrotic ring and dilate the site with the help of balloon. Endoscopic balloon dilatation is a treatment of choice for Skadsky's ring. Done? Sarkari question again. A patient presents with dysphagia, halitosis, and also with regurgitation of food. Same triad is seen. Regurgitation of food, halitosis, and dysphagia. Along with that, the patient is also having a swelling in the lateral aspect of the neck, beta. Okay. And when you press the swelling, beta, on pressing the swelling, it gives rise to which sound? Gurgling sound. When we press a neck swelling, and that gives rise to a gurgling sound. This kind. It is classical, known as, no, which sign? Boise or Bryce? It is a classical Boise sign. Bryce sign is Bryce sign is definitely heard in laryngosele, beta, where we press a swelling and that gives a hissing sound. That is a Bryce sign of laryngosele. So this is a Boise sign. Hmm. Shabash. Okay. Now, as the patient is coming to you with dysphagia, we have performed a barium swallow and the image has been given below, where you are able to see an outpouching from the posterior wall of the esophagus. And this outpouching is nothing else but Zenker's diverticulum. I hope all of you are quite aware, beta, that Zenker's diverticulum is also known as pharyngeal pouch. So as Zenker's diverticulum is not in the option, you have to mark it as the pharyngeal pouch. Answer has to be option D. Clear है बात? Zenker's diverticulum या pharyngeal pouch की अगर मैं बात करूं, तो it is true or false diverticulum? We know it is a false diverticulum because the muscle layer is not present basically, beta. It is pulsion or traction. It is a pulsion diverticulum, beta, because it happens due to increased intraesophageal pressure. Okay. Next important, if I talk about, is Zenker's is more common in young or elderly patient. Elderly patient. Next, most common site for development of Zenker's diverticulum is Killian's dehiscence. So the most common site from where the Zenker's diverticulum arises, beta, is known as Killian's dehiscence, between which two muscle fibers? The oblique thyropharyngeus and the circular cricopharyngeus muscle fibers के बीच में से आता है, ठीक है? तो Killian's dehiscence between thyro and cricopharyngeus muscle fibers. Important is in Zenker's diverticulum, the investigation of choice will be the barium swallow itself. Important is, okay, if barium swallow doesn't help, then we go for a CT with contrast. ठीक है? Important if they ask you, beta, is what should be the treatment in a case of Zenker's diverticulum? If it is a small Zenker's diverticulum, then the treatment is only making an incision or cuts over which muscle? Cricopharyngeus muscle. That is called as cricopharyngeal myotomy. So if it is small, then go for a cricopharyngeal myotomy plus minus diverticulectomy, beta. But if it is a large Zenker's diverticulum, then we have to perform procedures like diverticulopexy, or the best treatment is Dolman's procedure or Dolman's operation, which is diverticuloesophagostomy, where we cut the wall between diverticulum and the main esophagus, beta. Okay, that is important. याद रखना, छोटा होगा तो क्रिकोफेरेंजियल मायोटोमी with or without diverticulectomy, but अगर बड़ा होगा साइज में तो the treatment of choice has to be the Dolman's operation. याद रखना, लैरिंगोसील में ब्राइसी साइन होता है और उसमें डिस्फेजिया वगैरह कुछ नहीं होगा. अकलेजिया कार्डिया में डिस्फेजिया, हालिटोसिस सब कुछ होता है, बट स्वेलिंग नहीं दिखती बेटा इन पेशेंट्स ऑफ अकलेजिया कार्डिया, एंड नीदर आउट पाउचिंग विल बी सीन, रादर अ बर्ड बीक अपीयरेंस विल बी देयर. स्कैट्सगी रिंग में बेटा ओनली डिस्फेजिया इज द सिम्टम, and apart from that the patient will definitely have a constricting ring or a narrowing in the esophagus, not an outpouching. Clear? Chalo. Next is a classical diagnosis, beta, where a patient is a chronic alcoholic, presents to the emergency room, beta, with sudden onset hematemesis. Hematemesis is blood and vomitus, and that is a feature of upper or lower GI hemorrhage? Upper GI hemorrhage. He is a known case of chronic liver disease. Chronic liver disease is another name for cirrhosis. Which among the following is the most likely cause of the patient? It is a classical diagnosis of malarious or bleeding varices. Answer has to be option D, bleeding esophageal varices. This was a previous year question of FMG exam. याद रखना, malarious tier होता तो they should have given a history of chronic alcoholic patient having a binge drinking episode. Following binge drinking, patient should have multiple vomiting or retching episodes, and then the patient will have hematemesis. तो अल्कोहलिक पेशेंट दोनों में होता है, बट मैलरीवियस में बिंज ड्रिंकिंग या बिंज ईटिंग होना चाहिए, उसके बाद वॉमिटिंग या रेचिंग होना चाहिए, तभी मैलरीवियस कहलाएगा. क्लियर? विदाउट वॉमिटिंग और रेचिंग इट कैन नॉट बी मैलरीवियस. ठीक है. Bleeding esophageal varices mein beta, here there is no need of any binge drinking, no need of any vomiting or retching, still the patient has hematemesis over here. Clear? That is how you differentiate. Bohr-Haave syndrome may be binge drinking followed by vomiting and retching episode should be present, and Bohr-Haave mein the complete macular striatum should be present, that is chest pain, vomiting and subcutaneous emphysema. Perforated peptic ulcer mein, please remember hematemesis can occur beta, but along with that the patient should have features of peritonitis, as well as the patient should have a hollow, like patient should have definitely the gas under diaphragm beta, that should be present. Okay. Now important is definitely yahan pe chronic liver disease, why it is significant as a history, because due to chronic liver disease or cirrhosis a complication will occur, that is portal hypertension. And whenever there is portal hypertension or pressure in the portal vein increases, pressure at the sites of portosystemic anastomosis increase, causing three problems. First, in the lower esophagus, the esophageal vessels will dilate and become tortuous, forming esophageal varices. And then they will rupture, causing upper GI hemorrhage. Next, in the periumbilical region, the patient will develop caput medusae, when the periumbilical veins will dilate and become tortuous. And third, in the rectum, the patient will develop rectal varices. Few rectal varices will be hemorrhoids. Hopefully understood. So that is important to be remembered. अब मुझे बताओ that esophageal varices form at what pressure? So we know that esophageal varices form at a pressure of more than 10 millimeters of mercury, whereas that they bleed at what pressure? We know that esophageal varices start bleeding at a pressure of more than 12 millimeters of mercury. That is important to be remembered. Now important is, if they ask you beta, is about in cases of esophageal varices, when the patient has been brought to us, what is going to be the investigation of choice? Upper GI endoscopy. As you are able to see, we have done an upper GI endoscopy on which we are able to see this dilated and tortuous esophageal varices beta, which may bleed and cause upper GI hemorrhage. Clear? If they ask you, whenever a patient of bleeding esophageal varices has been brought to us, what is the first line treatment? Very good. The first line treatment in patients of bleeding esophageal varices, answer is basic resuscitation. Because due to bleeding, patient may be hemodynamically unstable. So give IV fluids. Next, what is the drug of choice? So the drug of choice will be IV octreotide, but a better agent will be terlipressin. So the drug of choice is IV octreotide, but a better agent is always terlipressin. If IV octreotide or terlipressin fails, then definitely a endoscopic band ligation or a banding has to be tried. And if banding cannot be done, the another alternative is sclerotherapy. शाबाश. ठीक है. तो endoscopic banding has to be done, or alternative is sclerotherapy, जहाँ पे 3% sodium tetradecyl sulfate is the sclerosing agent used. And last option is only a surgery called as is placed between the portal vein and the hepatic vein, so that the pressure in the portal vein decreases. Till the tip surgery, you have to control the bleeding commonly with the help of which tube? Sengstaken Blakemore tube. Shabash. Done with this? Next, if I talk about beta, the most common cause of upper and lower GI hemorrhage. Please tell me, upper and lower GI hemorrhage is definitely differentiated based on ligament of Treitz. Matlab, any bleeding above the ligament of Treitz is going to be upper. Have I become so predictable? Okay. So please remember, the most like any bleeding above the ligament of Treitz is upper GI hemorrhage. Any bleeding below the lower GI hemorrhage will be lower GI hemorrhage. Any bleeding below the ligament of Treitz will be lower GI hemorrhage. Important if they ask you, beta, is upper GI hemorrhage can present to you with blood in the vomitus called as hematemesis, or black tarry stools known as melena. So melena is a feature of upper GI hemorrhage. Whereas in lower GI hemorrhage, there is fresh blood in stools called as Hematochezia. Important. Most common cause of upper GI hemorrhage overall. Most common cause of upper GI hemorrhage is PUD, that is peptic ulcer disease. Which ulcers bleed more commonly? Duodenal ulcer. And which is the most common vessel to bleed? Gastroduodenal artery. Shabash. Second most common cause of upper GI hemorrhage will be gastritis. The most common vessel to bleed in gastritis will be left gastric artery. We know left gastric artery is the most common vessel to bleed in three conditions. First is gastritis. Second is it is malarious tear. And third is उसमें veins bleed होती है बेटा. Gastric ulcer. Very good. So gastritis, gastric ulcers, and malarious tear are the three conditions jahan pe the most common vessel to bleed is left gastric artery. But in PUD, it is the gastroduodenal artery. Lower GI hemorrhage, most common cause overall or in adult patients will be hemorrhoids or piles. The most common cause of lower GI hemorrhage overall or in adult patient will be hemorrhoids or piles. Most common cause of lower GI hemorrhage in children, rectal polyps, beta. Very good. So please remember, most common cause of lower GI hemorrhage in children is going to be rectal polyps, beta. Most common cause of lower GI hemorrhage in elderly patients will be diverticulitis. So diverticulitis is the leading cause of lower GI hemorrhage in elderly patients, beta. Hopefully clear to all of you now. So do remember that. Important is, if they say this is a patient who comes to you with, who is a chronic alcoholic patient, beta, सुनोगे पूरा तुम लोग. Chronic alcoholic है, उसमें कुछ भी हो सकता है फिर तो. तो chronic alcoholic patient definitely had a binge drinking episode, and following binge drinking episode, now he has repeated episodes of vomiting or retching. Now bolo, it is a diagnosis of malarious tear. तो बिना पकाए खाना नहीं खाना होता. तो alcoholic patient with binge drinking episode and repeated episodes of vomiting and retching, beta, has to be a classical diagnosis of malarious tear. If I talk about malarious tear, we have just now discussed the most common vessel to bleed in this condition will be the left gastric artery. To make a diagnosis, we will do an upper GI endoscopy on which you are able to see, beta, a partial tear in the esophageal wall starting from the gastroesophageal junction. If they ask you what is going to be the first line management, the first line management will be basic resuscitation, airway, breathing, circulation. If they ask you, sorry, what is going to be the definitive management? What is going to be definitive management? Nothing. Why? Very good. Because we know in majority cases of malarious tear, beta, there is a spontaneous resolution, which is a self-limiting condition. In case if the bleeding doesn't stop, then only we go for an angioembolization to stop the bleeding. Usually, no treatment is required. Yaad rakhna, majority cases mein no treatment will be given after stabilizing the patient. Next, another condition of upper GI hemorrhage. कैसा stomach दिख रहा है तुम्हें? Very good. We have performed a upper GI endoscopy in a patient with upper GI hemorrhage, and you are able to see a classical watermelon-like stomach. And watermelon-like stomach is a feature of GAVE, that is gastric antral vascular ectasia, where the submucosal gastric vessels have been dilated. The gastric antral vascular ectasia or GAVE. Treatment in patients of GAVE is APC. What is APC? Argon photocoagulation. So argon laser photocoagulation has to be done. Important. Another condition, again, the patient is presenting to you with upper GI hemorrhage or hematemesis. Upper GI endoscopy has been done, and it gives you appearance of the stomach like, yes, a brain-like appearance called as cerebriform appearance. So we know whenever upper GI endoscopy shows a cerebriform appearance of the stomach, it has to be a diagnosis of Menetrier's disease. We know that Menetrier's disease is due to which chemical mediator? TGF alpha, beta. So please remember TGF alpha, that is tissue growth factor alpha, is responsible for Menetrier's disease. That is important. In Menetrier's disease, we know, beta, that the patient will come to us with complaints of upper GI bleeding, but the main problem in the patient of Menetrier's disease is loss of proteins, and due to protein loss, the patient is going to develop edema, and due to loss of mucus, the patient will develop metabolic acidosis. So protein loss and acidosis are the two major problems in patient of Menetrier's disease. If they ask you, beta, in Menetrier's disease, do we need to take a biopsy? Yes. Why? Because we know that definitely Menetrier's disease is a pre-malignant condition, beta, which will increase the risk of gastric cancer. And that's the reason a biopsy is always required in the diagnosis of Menetrier's disease. And the treatment, initially it is a medical management, and the drug of choice will be cetuximab beta. So the drug of choice for Menetrier's disease is cetuximab. In case if it has progressed into the stage of cancer, we should go for gastrectomy beta. ठीक है, तो initial management is always cetuximab. In case if the patient doesn't respond, then go for gastrectomy in the patient. Understand. Now let's talk about the next one. And here you are able to see we are having a 4-week-old male newborn beta. A 4-week-old male newborn who was brought to us with complaints of projectile non-bilious kind of a vomiting bache. On feeding, the peristalsis is visible. An olive-shaped mass or a lump is felt in the epigastrium. Mother had taken which drug during pregnancy? They're asking you. Erythromycin. Very good. What is the likely diagnosis? CHPS. Why? Because the child has presented to us after 2 to 3 weeks of life, along with complaints of non-bilious vomiting, and with shaped lump, olive-shaped mass or lump is palpated. So the diagnosis of this patient has to be a classical case of CHPS, that is congenital hypertrophic pyloric stenosis. And in patients of CHPS, as the pyloric muscles have been hypertrophied, there is a functional gastric outlet obstruction causing a projectile vomiting. And as the food comes back from the stomach, the patient will have a non-bilious vomiting. That is what is important to be remembered. Now, as the child has a lot of vomiting, here the child will have a severe dehydration and electrolyte disturbance. The electrolyte disturbance present in patients of CHPS will be hypokalemic, hypochloremic, okay, metabolic acidosis or alkalosis. As acid is lost, metabolic alkalosis with paradoxical aciduria beta. This is the classical feature in patients of CHPS. So it is nothing else but hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria will be present. Important is in patients of CHPS beta, we know the risk is going to increase in the fetus when the mother has taken which drug during pregnancy? So whenever the mother has taken erythromycin drug during pregnancy, the risk of CHPS in the baby or the fetus is going to increase. Repeated question above. Now, important is whenever the child has been brought to us with complaints of non-bilious vomiting after 2 to 3 weeks of life, then we suspect CHPS and we go for a X-ray abdo. When we go for a X-ray abdo, what is seen? Single bubble sign, definitely. Now, important is if they say beta that the child is having vomiting at birth and that is bilious in nature with a double bubble sign on X-ray, that diagnosis is duodenal atresia. Then very good. We can also do a barium meal in the patient, and barium meal shows a narrow pyloric canal beta called as the string sign. A narrow pyloric canal called as string sign, and we are also able to see a shoulder or a mushroom sign as well. Hopefully clear to all of you now. So do remember that the string sign or mushroom sign on barium meal is also a feature of congenital hypertrophic pyloric stenosis. Important if I talk about beta is what is the investigation of choice. Though X-ray and barium meal can be done, but it is not the investigation of choice. We know for all abdominal problems a rule follows. For all children, the investigation of choice is ultrasound abdomen, and for all adults, investigation of choices CCT abdo-beta. So investigation of choice will be an ultrasound abdomen where the diagnosis of CHPS will be confirmed. Now, important is if they ask you, beta, in patients of CHPS, we have to proceed for the treatment. When I talk about the treatment, which the first step is obviously stabilizing the patient, and for that we have to give IV fluids. The fluid of choice to be given in patient of CHPS. The fluid of choice will be half normal saline plus 5% dextrose plus minus potassium क्लोराइड बेटा, KCl। अगर ये ऑप्शन में नहीं है, सेकंड बेस्ट आंसर इज नॉर्मल सलाइन। तो याद रखना, बेस्ट फ्लूइड इज हाफ नॉर्मल सलाइन प्लस 5% डेक्सट्रोज प्लस और प्लस माइनस पोटेशियम क्लोराइड। अगर वो ऑप्शन नहीं है, सिंगल बेस्ट आंसर विल बी नॉर्मल सलाइन। Which fluid has to be avoided in cases of CHPS? The fluid to be avoided in cases of CHPS, answer will be Ringer's lactate. Why? Because when lactate is broken down, it releases bicarbonates, which can worsen the metabolic alkalosis. That's the reason. If they ask you what is the treatment of choice in patient, the treatment of choice in patients definitely has to be a Ramsted's pyloromyotomy. The treatment of choice has to be a Ramsted's pyloromyotomy. Heller's myotomy for Acrasia cardia and Ramsted's pyloromyotomy for CHPS beta. Hopefully clear to all of you now. Chalo. Next important if I talk about is another case over here which states we have a neonate beta who has presented to us with complaints of bilious vomiting and that too immediately at birth beta. The X-ray has been given below which shows how many bubbles. It definitely shows the classical double bubble sign. Double bubble sign on X-ray abdomen is seen in duodenal. Apart from that, annular pancreas and Lads band. तो याद रखना, duodenal atresia, annular pancreas and Lads band are the three condition beta जहाँ पे we are able to see a double bubble sign on an X-ray abdo. That is what is important to be remembered. Important is हमें पता है कि in patients of duodenal atresia how to differentiate it from CHPS. यहाँ पे भी the neonate is brought to you, but the neonate will be brought to you immediately at birth beta because duodenum is not fused with each other. Second, the patient will have a bilious vomiting because the food is coming back from the duodenum after mixing with bile. That is the difference. Okay, hopefully clear. And X-ray abdomen confirms it further by showing a double bubble sign. But the best confirmatory diagnosis, best investigation of confirmatory diagnosis will be done by only condition in neonates beta जहाँ पे a CCT abdomen is required and answer is duodenal atresia. See, usually for all the other abdominal problems, ultrasound is enough. Only condition जहाँ पे CCT abdomen is the investigation of choice for a neonate, answer is duodenal atresia. In patients of duodenal atresia beta, okay, once you have confirmed the diagnosis by CCT abdomen, what should be the treatment? Both the ends are not connected to each other. Now just perform an anastomosis. That is a duodenostomy beta, also called as a duodenal anastomosis. If the gap is too much, then go for a DJ-stomy or a duodenojejunostomy. Prefer a duodenostomy. Not possible, then go for a DJ-stomy. Understood? Next important, if I talk about beta, is nothing else but intestinal obstruction now. Done? If I talk about intestinal obstruction beta or bowel obstruction, we know it is one of the important surgical and common surgical emergencies beta. Intestinal or bowel obstruction can be of two types, dynamic or adynamic. When there is a physical obstruction, then it is called as dynamic intestinal obstruction. When there is no physical obstruction but no motility, adynamic. Most common cause of dynamic intestinal obstruction is adhesions. So when adhesions are formed inside the bowel beta, that can cause a physical obstruction leading to a dynamic bowel obstruction, followed by second most common cause will be strictures beta. Whereas most common cause of adynamic intestinal obstruction will be, we know in adynamic intestinal obstruction, there is no physical obstruction, but the problem is bowel is not able to perform peristalsis. That means the bowel is paralyzed. That is called as paralytic ileus. Most common cause of paralytic ileus. Most common cause for paralytic ileus is surgery beta. So during surgery, when we do too much of bowel handling, that is known cause for paralytic ileus. Most common electrolyte disturbance causing paralytic ileus will be hypokalemia. So hypokalemia is known to increase the risk of paralytic ileus. But yaad rakhna, overall most common cause is not electrolyte disturbance, it is surgery. If they ask you what are the symptoms in patients of intestinal obstruction beta, we know if there is an obstruction, patient is not able to pass feces called as constipation, not able to pass flatus, तो गैस पास नहीं कर पाता, that is obstipation. Due to both of this, the patient will have a severe abdominal distension. Apart from that, in dynamic intestinal obstruction, as there is a vigorous peristalsis, patient will have a pain abdomen beta. Or lastly, a late feature will be vomiting. Bowel obstruction में vomiting will be seen, but it will be a very late feature beta. That is important. अब अगर वो पूछते हैं बेटा first investigation, तो first investigation in any patient coming to you with bowel obstruction, answer has to be a X-ray abdomen beta. And we know X-ray abdomen in bowel obstruction has to be taken in two views beta. First, when the patient is standing, that is called as erect view beta. And second, when the patient is lying supine, when the patient is lying, that is supine view. Important, erect view will tell you what? Erect view will tell you that whether your patient is having an obstruction or not. When do we say that the patient is having bowel obstruction? So यहाँ पे you should have been able to see continuous bowel loops, but here you are able to see breaks, that is called as air fluid levels. So when the X-ray abdomen erect view shows you air fluid levels more than 3, that is diagnostic of intestinal obstruction. Next important, if I talk about X-ray abdomen, supine view will tell you about what? It will tell you about the site or the location of obstruction, whether it is a large bowel or a small bowel obstruction. If it is a large bowel obstruction, the distended bowel loops are in the periphery beta. And second important, the classical feature is known as horstrations will be present. ठीक है, as ये जो होता है ना peripheral constrictions, those are horstrations. If it is a small bowel obstruction, the distended bowel loops are in the center beta. The distended bowel loops are in the center. If it is a jejunal obstruction, you are able to see which pattern? So if it is a jejunal obstruction, you are able to see a step ladder pattern. Why? Because jejunum contains continuous mucosal folds called as valvulae coniventis. Next, ileal obstruction mein, is there any special feature? So it is characterless or featureless loops. So featureless loops, if they are seen beta, that is a feature of ileal obstruction. Understood? So that is what is important to be remembered. अब यहाँ पे बताओ मुझे, X-ray abdomen supine view shows you which kind of pattern? मुझे ये बताओ, X-ray abdomen supine view is showing you distended bowel loops in the center or periphery? Center. मतलब it is a small bowel obstruction. Small bowel obstruction में it is jejunal or ileal? Jejunal. Why? These continuous mucosal folds are seen, which is showing you a step ladder pattern. That means it is a case of jejunal obstruction. So it is a case of a jejunal obstruction. Hopefully clear to all of you now. Now important is investigation of choice for bowel obstruction will be bowel obstruction के लिए the investigation of choice is CCT abdomen, which confirms the diagnosis, and treatment for bowel obstruction is surgery or conservative. So bowel obstruction के cases में the treatment is usually a conservative management beta. And when I talk about a conservative management in surgery, चार चीजें क्या करते हैं अपन? Keep your patient NPO, nil per oral, give IV fluids, give IV antibiotics, and pain के लिए analgesics. तो याद रखना, NPO, IV fluids, IV antibiotics and analgesics have to be given in conservative management of bowel obstruction. अब हमें पता है that majority cases will improve after conservative management, but some cases may not. And those cases which fails to respond to conservative management will be taken up for surgery, and the surgery for bowel obstruction will be exploratory laparotomy. So you will perform an exploratory laparotomy and find the site and cause for obstruction and treat it. Clear? Chalo. So that is what is important to be remembered. Understood? So that was about your intestinal or bowel obstruction. हमें पता है X-ray abdomen, if it is showing single bubble sign, it is a diagnosis of CHPS, that is congenital hypertrophic pyloric stenosis. If X-ray abdomen is showing you a double bubble sign, it could be three conditions. First is duodenal atresia, second is annular pancreas, and third is Latz band. Triple bubble sign on X-ray abdomen. तो यहाँ पे क्या दिख रहा है? ट्रिपल बबल साइन. एंड हमें पता है जब भी ट्रिपल बबल साइन विल बी सीन ऑन एक्सरे एब्डोमेन, इट हैज टू बी अ डायग्नोसिस ऑफ जेजुनल अट्रेजिया. इलियल अट्रेजिया में क्या दिखेगा फिर? वेरी गुड. तो हमें पता है अगर एरियल एट्रेसिया होता है तो वी आर नॉट एबल टू काउंट द नंबर ऑफ बबल्स, तो वी कॉल इट एज द मल्टीपल बबल साइन beta. If multiple bubble sign is seen on the X-ray abdo, as you're able to see over here, this is a classical picture of ideal atresia. And you can see these are ideal loops beta mainly. Hopefully clear. Chalo. So that is what is important to be remembered. So bubble sign, so bubble appearance on X-ray abdomen is a feature of peritonitis. So bubble appearance on X-ray abdomen is a feature of peritonitis beta. That is important. Done. Next, answer this question over here. It states we are having a 50-year-old patient beta presents to the hospital with upper GI bleeding and abdominal pain. On CECT, tumor was detected bache, arising from the stomach, and it is showing an extraluminal growth. The tumor, extraluminar means it is not growing in the stomach, it is growing inside the wall. And the tumor is positive for which tumor marker? CD117 beta. Okay, which among the following is incorrect about the patient's diagnosis? Bolo. What is incorrect about the patient's diagnosis? What you are suspecting it to be?
Just
Provisional diagnosis is of a tumor called as GIST, that is gastrointestinal stromal tumor. Bolo answer. Bolo ABCD. Answer is option D. Endoscopic biopsy is the best investigation is an incorrect statement. Endoscopic biopsy is not recommended in the diagnosis of GIST. Okay, CECT abdomen is the investigation of choice. Why? We know that GIST is a mesenchymal tumor, so it will have a lot of blood vessels. And that's the reason the most common clinical presentation is also upper GI bleeding. If you try to take a biopsy, the patient will bleed too much. Therefore, upper like biopsy is never recommended in the diagnosis of GIST. Answer has to be option D. So it does a classical diagnosis of GIST beta, which is the most common mesenchymal tumor of the GI tract. Important, GIST is due to which gene mutation? We know that GIST is mainly due to a c-KIT gene mutation beta. Whereas if they ask you which is the most common tumor marker, most common tumor marker for GIST, answer is CD117. But if they ask you which is the best tumor marker, so we know the best tumor marker for GIST is going to be dog1 beta. So dog1 is considered as the most specific or the best tumor marker for GIST beta. So ये pathos से important questions है. Do remember that. Now important is if I talk about GIST बच्चे, we know the most common presentation over here is upper GI bleeding. If they ask you option A, treated with segmental resection, yes. इसीलिए तुम सर्जरी में पढ़ते हो ना उसको, ये तो मेडिसिन में नहीं पढ़ाया जाता जस्ट में. तो ट्रीटमेंट इज यस सर्जिकल रिसेक्शन इटसेल्फ बेटा. तो a segmental resection along with some normal margins has to be done. Why? Because majority cases of GIST are going to be benign in nature. ठीक है. So all the benign GIST are always treated with surgical or a segmental resection itself. मतलब the part of stomach which is having that GIST, remove that part. That is segmental resection. Next, first line agent is imatinib mesylate. Yes, but in which cases? Only in cases which are metastatic or malignant. So please remember, this is a true statement that for a metastatic or a malignant GIST, the drug of choice is imatinib mesylate beta. Please remember, in metastatic or malignant GIST, we don't go for a surgery. In that, we go for imatinib drug. Imatinib is the drug of choice for malignant or meta. Shabash. It is also the drug of choice for CML, that is chronic myeloid leukemia. Shabash. Now, if they ask you option C, gold standard investigation for recurrence is PET-CT, yes. So if there is a recurrence of just beta, the gold standard investigation will be a PET-CT, which is a whole body scan. That is important to be remembered. No issues with this, anybody? Clear about? So that is important to be remembered. If they ask you another question over here, beta, and that is about a 35-year-old male beta who has been diagnosed with cellulitis, which has been started on an antibiotic that is clindamycin. But the patient presents to you with watery diarrhea and abdominal pain, beta. Colonoscopy was performed and the following picture has been obtained. Which among the following is incorrect about the patient's condition?
D is Pavitra.
What is your provisional diagnosis? Very good. The provisional diagnosis of this case is a case of pseudomembranous colitis beta. We know pseudomembranous colitis jab hota hai, here it happens after intake of a broad spectrum antibiotic. So now due to broad spectrum antibiotics, what is going to happen beta? The good bacteria of your gut are going to be killed and the pathogenic bacteria will start growing, causing colitis beta. And these exudates are going to be formed over the colonic wall that is known as pseudomembrane. So pseudomembranous colitis के लिए which is the most common drug responsible? Most common drug responsible for causing pseudomembranous colitis. कौन सी ब्रॉड स्पेक्ट्रम एंटीबायोटिक ज्यादा कॉमनली यूज करते हो? तुम्हें जैसे ही ब्रॉड स्पेक्ट्रम एंटीबायोटिक पूछते हो एक ही जवाब देते हो बस, थर्ड जनरेशन सेफेलोस्पोरिन्स. रीजन कॉमन है सबसे ज्यादा, मोनोसेफ बहुत कॉमनली यूज किया जाता है आजकल बेटा. तो पहले क्लिंडामाइसिन था, अब नहीं है. अब मोस्ट कॉमन ड्रग रिस्पॉन्सिबल इज थर्ड जनरेशन सेफेलोस्पोरिन्स लाइक सेफ्ट्राक्सोन, followed by the second most common drug responsible is clindamycin. Sorry. Next important, if they ask you which is the pathogenic bacteria that will grow, so we know beta that the Clostridium difficile is the pathogenic organism which grows and it is known to release the toxins which are known to cause colitis. So as Clostridium difficile is known to release toxins, what will be the investigation of choice? Stool cytotoxin assay. This is also a correct statement that this condition, pseudomembranous colitis, is diagnosed by a stool cytotoxin assay. Recent NEET PG question. Okay, important. अब if I come to treatment, we know if the cause is basically these broad spectrum antibiotics, we have to immediately stop those antibiotics beta. So here option C is also a true statement that clindamycin or any other antibiotic responsible should be stopped. And what is the treatment then? Is it a surgical resection? No, the treatment is medical management beta. So option D, that is surgical resection of colon is required, is a wrong statement beta. Because treatment is definitely an antibiotic and that is fidaxomicin beta. So please remember fidaxomicin can be given, or the only antibiotic where a oral indication is pseudomembranous colitis, it is vancomycin. So vancomycin is normally given injectable route से. Only oral indication of vancomycin is pseudomembranous colitis. ठीक है? Next question is over here बेटा. बोलो क्या है ये? अब if I talk about beta, a person comes to you with a soft fluctuant swelling in the umbilical region beta. On examination, when you do a percussion, a zone of resonance is noted all around the swelling. Around the swelling, there is a zone of resonance beta. And third, swelling moves perpendicular to the mesentery beta. So it moves in perpendicular direction to the mesentery, which is. What is this triad called as? Very good. So this is classically called as the Tilloch's triad beta. And I hope all of you are quite aware that Tilloch's triad is a feature of mesenteric. Tilloch's triad is a feature of mesenteric cyst. Answer has to be option D beta in this case. अब मुझे पता है आधे लोग जिनको पता भी है टिलॉक्स ट्रायड, वो एग्जाम में जाके क्या करोगे? इधर तो तुमने सही मार्क किया है, तुम्हारी गलतियां बता रहा हूं मैं. एग्जाम में जाके तुम क्या करोगे? इतना खुश कि ये तो मुझे आता है, तुमने ये पढ़ा, हाँ आंसर आगे बढ़े, और फिर घर आके रोते हो कि मैंने क्यों नहीं मार्क किया जब मुझे पता था. तो इसीलिए मैं बोलता हूँ पूरा पढ़ा करो, कोई ट्रेन नहीं पकड़नी होती एग्जाम के बाद जाके तुम्हें. ठीक है, तो प्लीज रिमेंबर दैट. So Tellox triad is going to be there. We know we have studied mainly about two types of mesenteric cyst, chylolymphatic and enterogenous. ये वाला कौन सा दिख रहा है पिक्चर में? We know that the more common type of mesenteric cyst is a chylolymphatic cyst, where there is a collection of lymphatic fluid बच्चे inside the mesentery. So it is a case of chylolymphatic cyst. We know that definitely for the diagnosis of mesenteric cyst, the investigation of choice will be all abdominal problems. Ultrasound can be done, but better investigation is a CECT abdo. So investigation of choice for a mesenteric cyst is a CECT abdomen beta. And if they ask you what should be the treatment, if it is a chylolymphatic cyst, the treatment is only removal of cyst, and removal of cyst will be called as enucleation. तो अगर काइलोलिम्फेटिक सिस्ट है, द ट्रीटमेंट इज ओनली रिमूवल ऑफ द सिस्ट, दैट इज इन्यूक्लिएशन. अगर एंड्रोजेनस सिस्ट है, देन ट्रीटमेंट इज रिसेक्शन एंड एनास्टोमोसिस. चलो, अब मीजेंट्रिक अडिनाइटिस का केस कैसा होगा? प्लीज रिमेंबर, दे विल से द पेशेंट इज अ स्मॉल चाइल्ड coming to you with a long history of abdominal pain. Why long history I'm saying? Because mesenteric adenitis or mesenteric lymphadenitis is the infection of mesenteric lymph nodes in the abdomen. अब most common cause for mesenteric lymphadenitis in India is TB. इसीलिए मैं बोल रहा हूँ लॉन्ग हिस्ट्री होगा. क्लियर? तो मोस्ट कॉमन द child will be there with a long history of abdominal pain, beta. Okay, so that will be a classical feature. Sometimes the patient may also have other features of bowel obstruction as well. That is a classical case of mesenteric adenitis. And mesenteric adenitis is a very close differential for acute appendicitis. Mesenteric adenitis can be a very close differential for an acute appendicitis ka case. याद रखना. Next, abdominal cox is also any kind of abdominal tuberculosis, beta. Appendicular lump which is there, यहाँ पे the patient should have been given a history of acute appendicitis, after which when you palpate the right iliac fossa, you are able to feel a mass or a lump, beta. That is a diagnosis of appendicular lump. Hopefully clear to all of you now. Next is a sarkari question of your examination, and that is, a child has underwent an elective surgery, beta. Following abnormality was detected incidentally. Incidentally matlab you were doing the surgery for some other condition, and by chance you have observed this particular problem, beta. They are asking you which among the following is true about this given condition. Answer क्या होगा? बोलो, ABCD. प्रोविजनल डायग्नोसिस क्या है? तो provisional diagnosis of this case is nothing else but a Meckel's diverticulum, which is an outpouching from the midgut, beta. We know that Meckel's diverticulum, which is there, it is a false or a true diverticulum. We know as Meckel's diverticulum is present since birth, it contains all the layers, beta, and it is an example of true diverticulum. And it is present on mesenteric or anti-mesenteric border. The Meckel's diverticulum is present on anti-mesenteric border. It follows which rule? We know that Meckel's diverticulum follows the rule of two. That is, it is seen in 2% of the population. It is 2 inches long. It is 2 feet proximal to the ileocecal junction, beta. And 20% patients will have an ectopic mucosa. Most common ectopic mucosa. That is important. So option A is a wrong statement, beta, because most common ectopic mucosa is not pancreatic. It is the gastric mucosa that is present in a mesenteric, the Meckel's diverticulum. This has been a previous year question, which is the most common ectopic mucosa. Next important is, if they ask you, option B says best investigation is CCT scan. No. Very good. We know the investigation of choice in patient of Meckel's diverticulum is technetium 99. System or per technet? So technetium 99 per technet scan, beta. Technetium 99 system scan is used for. Very good. For any parathyroid gland pathology, beta, the investigation of choice will be technetium 99 system scan. So per technet for Meckel's diverticulum, system for parathyroid gland problems. That is important. Option C says bleeding per rectum is the most common presentation. Yes. Majority patients are asymptomatic, beta. याद रखना. But in case if symptoms है, the most common presentation will always be bleeding per rectum, बच्चे. Pain is not a very common symptom. Option D says it contains submucosa and muscularis propria. No, it contains all the layers. Mucosa, submucosa, as well as muscularis. तीनों होंगे तो ही true diverticulum कहलाता है. Important if I talk about Meckel's diverticulum जो होता है बेटा, in this condition, it is due to partial patency of which embryological structure? Very good. We know that Meckel's diverticulum happens due to a partial patency of the vitello-intestinal duct, also known as omphallomesenteric duct. Complete patency of vitello-intestinal duct leads to formation of vitelline fistula. And in vitelline fistula, what comes out from the baby's umbilicus? Meconium, beta. Meconium or stools, if they come out from the baby's umbilicus, that means the vitello-intestinal duct is completely open, and that is a diagnosis of vitelline fistula. Agar urine is coming out from the baby's umbilicus, it is a urachus fistula. If urine comes out from the baby's umbilicus, it is a urachus fistula, and that is due to complete patency of the urachus or allantois. Clear? That is important to be remembered. अब याद रखना बेटा, in patients of Meckel's diverticulum, if that Meckel's diverticulum is herniated beta, then it is a diagnosis of. Very good. So agar Meckel's diverticulum is a part of the hernial sac, if Meckel's diverticulum is a part of the hernial sac, then that kind of hernia will be called as the Litter's hernia. If appendix is a part, Amiens hernia beta. So if appendix is a part, then it is known as an Amiens hernia. That is important to be remembered. Clear? अगर वो पूछते हैं that what is going to be the treatment in a patient of Meckel's diverticulum, in case if I say it is having a wide mouth and a wide base, नो ट्रीटमेंट. ठीक है, अगर वाइड माउथ है वाइड बेस है बेटा तो नो ऑब्स्ट्रक्शन, तो क्यों करोगे ट्रीटमेंट, लीव इट एज इट इज. बट इफ इट इज हैविंग अ नैरो माउथ एंड अ नैरो बेस बेटा, तो नैरो मेकल्स डायबिटिकुलम में यू श्योरली नीड टू गो फॉर अ ट्रीटमेंट बिकॉज चांसेस ऑफ ऑब्स्ट्रक्शन आर हाई एंड द ट्रीटमेंट विल बी removal, that is diverticulectomy. Understood? That is about your Meckel's diverticulum that you need to remember. Next, if I talk about beta, is nothing else but a classical diagnosis of intersusception, another common question. Now, when I talk about intersusception, इसका मतलब क्या होता है? Yes, when one part of the bowel goes into the adjacent part of bowel, that is called as intersusception. एक हिस्सा साइड वाले हिस्से में जब घुस जाता है bowel का या intestine का, that is intersusception. We know intersusception is more common in children or adults. Children, we know that primary intersusception जो होता है, तो it is more common in which age group? 6 months to 2 years of age. Primary intersusception is more commonly seen in 6 months to 2 years of age beta. Second most common site for primary intersusception will be. Very good. We know that the most common site for primary intersusception is the iliocecal or the iliocolic junction beta. And third, what is the main cause for primary intersusception? So please remember the cause for a primary intersusception is nothing else but hypertrophy of the pairs patches beta. What are pairs patches? So we know pairs patches are the lymphoid tissue of the ileum. So lymphoid tissue of ileum is basically called as pairs patches और उसकी जब hypertrophy हो जाती है तो the patient develops intersusception. Another question, which vaccine is responsible for causing intersusception? Shabash. So we know definitely the vaccine that is known to cause intersusception is the rotavirus vaccine because it causes diarrhea and that increases the risk of intersusception beta. Clear hai baat? Chalo. If I talk about intersusception, patient will surely come to us with complaints of bowel obstruction. So same complaints of bowel obstruction will be there beta, but along with that sometimes patient will have blood and mucus containing stools, and that blood and mucus containing stool will be called as red currant jelly stools. Red currant jelly stools are a feature of intersusception. Red currant jelly sputum in Klebsiella pneumoniae. So Klebsiella pneumoniae there is a red currant jelly sputum. Olive shaped lump is a feature of hypertrophic pyloric stenosis. But in cases of intersusception, which shaped lump is there? So in patients of intersusception, there is a sausage shaped lump beta that is going to be palpated. Hopefully clear. अगर वो बोलता है what is going to be the investigation of choice in patients of intersusception, तो हमें पता है the investigation of choice in intersusception answer has to be ultrasound abdomen, and when for children ना adults के लिए CCT again. So ultrasound abdomen when we do beta you are able to see a very classical sign. So you are able to see beta two loops of intestine, one inside another. That is known as the target sign, also called as the donut sign beta. So target sign or donut sign on ultrasound abdomen is a very classical feature found in patients of intersusception. You can also get a pseudo kidney sign at times. ठीक है? Next important, this is the classical picture of intersusception. Important is beta definitely. If they say investigation of choice, then it is usually an ultrasound. But if they say gold standard, then answer is barium enema. Normally we know beta that barium study is not gold standard, but here this is the condition jahan pe the gold standard investigation for intersusception is definitely going to be a barium enema or a contrast enema beta. Why? Very good. Because contrast enema is not only diagnostic but even therapeutic in patients of intersusception. It helps us in treatment. What is the classical sign? Very good. Here we are able to see a claw sign or a pincer sign, beta. Apart from claw sign or pincer sign, you are also able to see coiled spring sign. So claw or pincer sign along with coiled spring sign on a barium enema is a classical diagnosis of intussusception in the patient. Now, if they ask you what is going to be the treatment in a patient of intussusception, very good. The initial treatment we will always try, beta, should be less invasive. That is, we will pass the catheter for barium enema, beta. जो barium push करने के लिए जो catheter अंदर डालोगे, उसी catheter के मदद से you have to push either water or air, beta. If you push water, it will be called as hydrostatic reduction. If you push air, it will be called as pneumostatic reduction. As pressure is coming from below, this part which has gone inside slowly comes outside, beta. So this is literally called as the hydrostatic or a pneumostatic reduction. अगर हाइड्रोस्टैटिक और नीमोस्टैटिक रिडक्शन फेल हो जाता है, very good. If hydrostatic or pneumostatic reduction fails, then we go for a exploratory laparotomy, and on laparotomy we are performing a manual reduction. Whenever we do manual reduction for intussusception, we should pull or push. Always push, never pull, because otherwise it will increase the risk of perforation or strangulation. So हमेशा distal part को दबा के बेटा, you have to push this intersuscepted part out. This is what is called as always push, never pull. Hopefully that's clear to all of you now. That was all about your intersusception. अगर perforation है तो resection and anastomosis करेंगे हम, बराबर complicated cases में. चलो, next important is a case जहाँ पे we have a neonate beta who was brought to the pediatric emergency room with complaints of no passage of meconium. Normally, meconium should be passed within a span of 48 hours, and urine should be passed within a span of 24 hours. Here, the patient might not have, or the neonate might not have passed meconium even after 48 hours. So it could be considered as a diagnosis of meconium ileus. Meconium ileus can be seen in two conditions in children, beta. For differentiation, we have to do a digital rectal examination. And when I do a digital rectal examination, if the meconium floods out, अगर बारिश हो जाती meconium की, it is a diagnosis of Hirschsprung's disease. Now we know if the meconium floods out, it is a classical diagnosis of Hirschsprung's disease, which is also called as congenital aganglionosis, beta. हमें पता है Hirschsprung's disease में why the meconium floods out, because when I perform a DRE, there is stimulation of the rectum, which is not normally occurring, and due to that the meconium floods out, beta. ठीक है? तो please remember. तो Hirschsprung's disease में we know there is absence of ganglionic cells, बच्चे. In Hirschsprung's disease, there is absence of ganglionic cells. In which plexus of the GIT? In both the plexus, beta, that is the Meissner's as well as the Orbach's or the Mantric plexus. So, yaad rakhna, definitely in patients of Hirschsprung's disease, beta, the ganglionic cells are absent from both the plexuses, beta, that is the Meissner's as well as the Orbach's plexus. दोनों से अगर absent है ganglionic cells, that is a classical diagnosis of Hirschsprung's disease. अगर meconium flood out होता है, then it is diagnosis of Hirschsprung's. If on performing DRE, if the meconium does not flood out, meconium बाहर ही नहीं आ रहा, तो it is a diagnosis of cystic fibrosis, बेटा. That is important. क्यों? क्योंकि cystic fibrosis में the meconium is extremely hard or thick, बेटा. कड़क होने की वजह से even on performing DRE, the meconium does not come out in cystic fibrosis. That is what is important to be remembered from pediatrics also. ठीक है? Now, if they ask you in patients of Hirschsprung disease, हमें पता है that this condition and like Hirschsprung disease and duodenal atresia both are commonly associated with which condition? Down syndrome. अगर वो पूछेंगे that in cases of Hirschsprung disease, what is the investigation of choice? क्या करोगे? If you want to see that ganglionic cells are present or absent, that investigation of choice has to be a rectal biopsy. Why? Because we know that most common site for Hirschsprung disease is the rectosigmoid area, beta. So investigation of choice has to be rectal biopsy, a full thickness or a suction rectal biopsy, which shows absence of ganglionic cell. Next important, if they ask you if you want to see that how much is the length of the aganglionic segment, then the investigation to be done is either a MRI or a barium enema. याद रखना, to see the extent of the disease, either a MRI or barium enema has to be done, जहाँ पे you can see that the aganglionic segment will be collapsed or dilated. collapsed. तो जो segment collapsed है बेटा, that is going to be aganglionic in nature, and the segment which is dilated is actually the normal segment beta. Understood? Now if they ask you in this condition what should be the treatment, so here definitely we know beta that in this condition whatever segment is aganglionic we have to cut it out, that is resection and anastomosis, and the surgeries which are there they are named as Duhamel's operation, Swenson's operation, or Stowe and Park's operation beta. These are the three surgeries that you can perform. Any of the surgery can be performed beta. So याद रखना तीन सर्जरी के नाम for Hirschsprung's disease. First is Duhamel's surgery, second is Swenson's surgery, and third is Stowe and Park's surgery beta. Understood? Understood? Next is a case when a patient comes to us with features of bowel obstruction, and when I do a X-ray abdomen, I am able to see two air fluid signs. That is a classical diagnosis of sigmoid volvulus. यहाँ पे X-ray abdomen is showing you which sign? Coffee bean sign बेटा. Please tell me coffee bean sign definitely में कितने air fluid levels होते हैं? Two air fluid levels are seen beta in coffee bean sign. Single air fluid sign on X-ray abdomen is a feature of वेरी गुड सीकल वॉल्वुलस. अगर टू एयर फ्लूइड साइन है, मैंने बोला था टीएनडी में टू एयर फ्लूइड साइन है बेटा, तो इट इज अ केस ऑफ सिग्मोइड वॉल्वुलस, एंड सिंगल एयर फ्लूइड साइन इज देयर, दैट इज अ केस ऑफ सीकल वॉल्वुलस. दैट इज व्हाट इज इंपॉर्टेंट टू बी रिमेंबर. ठीक है, so we know that here two air fluid signs are seen, two air fluid levels are seen, therefore it is a case of coffee bean sign beta. And barium enema is showing you which appearance. So we know that barium enema shows you a classical bird beak appearance, also known as bird of prey sign, also known as ace of spade sign beta. ठीक है, and coffee bean sign and bird beak appearance, this is classical features of sigmoid volvulus. Volvulus is nothing else but twisting or malrotation of any organ is called as volvulus. The most common site in the GIT for volvulus is the sigmoid colon itself beta. So sigmoid volvulus is very commonly seen. Important, sigmoid volvulus में, as I've told you, the patient will complain of bowel obstruction. So all the signs and symptoms of bowel obstruction will be present. Investigation of choice for bowel obstruction is always CECT abdomen. Investigation of choice will be CECT abdomen. Treatment, अगर it is a non-complicated case, मतलब कोई कॉम्प्लिकेशन नहीं है पेशेंट में, अनकॉम्प्लिकेटेड केस ऑफ सिग्मोइड वॉल्वुलस में इमरजेंसी ट्रीटमेंट बताओ. पहले कंजर्वेटिव मैनेजमेंट करोगे, बट देन वंस यू डायग्नोज इट एज सिग्मोइड वॉल्वुलस वी गो फॉर sigmoidoscopic decompression. matlab pass a sigmoidoscope in the patient sigmoid colon and remove all the air with the help of an empty syringe beta. Why? Because if you aspirate the air, the pressure in the sigmoid colon is going to decrease, and the colon that has undergone twisting beta, it may come back into its normal position. So that is called a sigmoidoscopic decompression. But definitive treatment क्या होगा, इसके बाद क्या करोगे? Sigmoidopexy or sigmoidectomy? बेटर इज ऑलवेज अ सिग्मोइडेक्टमी बेटा, बिकॉज ना रहेगा बास ना बजेगी बांसुरी, तो लेस चांस ऑफ रिकरेंस विल बी सीन बच्चे आफ्टर यू परफॉर्म अ सिग्मोइडेक्टमी. सो ऑलवेज सिग्मोइडेक्टमी इज प्रेफर्ड ओवर अ सिग्मोइडोपेक्सी. ठीक है, ये तो हो गया अनकॉम्प्लिकेटेड केस के बारे में. बट अगर पेशेंट तुम्हारे पास परफोरेशन पेरिटोनाइटिस में आता है, दैट इज कॉम्प्लिकेटेड केस ऑफ sigmoid volvulus, then complicated cases of sigmoid volvulus mein beta, the surgery that we do is exploratory laparotomy plus peritoneal lavage plus sigmoidectomy and a temporary colostomy. Very good. The surgery is known as Hartmann surgery beta. Hartmann surgery is done for two conditions. First, it is seen in complicated sigmoid volvulus, and second, complicated diverticulosis of colon. Understood? Chalo. Next important if I talk about is a barium enema picture beta. Is barium enema pe what you are able to see? So in this barium enema, I am able to see which appearance? Which appearance? वेरी गुड. थंबप्रिंट अपीयरेंस बेसिकली यहाँ पे फिलिंग डिफेक्ट्स दिख रहे हैं बेटा. As we are able to see filling defects definitely over here, so it is the classical thumbprint appearance. And if I say that thumbprint appearance is seen on barium enema, it is a classical case of, very good, it is a classical case of mesenteric ischemia which can further lead to ischemic colitis. याद रखना, in patients of ischemic colitis or mesenteric ischemia beta, you are able to see a thumbprint appearance on barium enema. Please tell me which that thumb sign on X-ray neck is a feature of acute epiglottitis. Very good. Thumbprint sign is a feature of ischemic colitis. No issues with this, anybody? याद रखना है बस. ठीक है. Important, ischemic colitis happens due to mesenteric ischemia, and mesenteric ischemia का cause क्या होता है? Embolization. तो ischemic colitis which is there, it happens due to mesenteric ischemia और उसका cause होता है mesenteric artery embolism बेटा. तो mesenteric artery embolism which is there, it is the most common cause leading to ischemic colitis, mesenteric artery embolism. ठीक है. Next important, if I talk about beta, is this picture. Another barium enema, जहाँ पे you are able to see a very classical appearance. क्या है ये appearance? Apple core appearance. If you are able to see a apple core appearance on barium enema, it is a feature of colon cancer. Apple core appearance on barium swallow is a feature of esophageal cancer. Very good. तो colon cancer या colorectal cancer की अगर मैं बात करूँ बेटा, in colon और colorectal cancer, what is the most common site? Very good. So rectum is the most common site beta for colon cancer, followed by the sigmoid colon. So rectum followed by sigmoid colon is the most common site for colorectal cancer. In patients of colorectal cancer, patient will come to you with features of altered bowel habits. That is, usually patient may have this diarrhea or constipation. Patient may definitely, sorry, patient may give you a very prolonged history of constipation. Patient may have a severe weight loss as well, beta. Which gene mutation you will be able to find in colon cancer? Very good. Important gene mutation, beta, in cases of colon cancer is the KRAS gene mutation. KRAS gene mutation is known to cause colorectal cancer as well as pancreatic cancer, beta. That is what is important to remember. Others can be P53 or APC also. That is important. Now, if they ask you about colorectal cancer, beta, what is going to be the investigation of choice in this patient? Barium enema will be one of the first line investigations, not the investigation of choice. To confirm the diagnosis, we will go for colonoscopy with. Very good. The investigation of choice definitely in colorectal cancer is colonoscopy with biopsy beta that we have to perform. The investigation of choice for T and N staging. N matlab nodal staging. Very good. So we know that tumor and nodal staging agar karni hai beta, so we need a investigation like MRI. For esophageal and gastric cancer, if you want to do a tumor and nodal staging, the investigation of choice will be एंडोस्कोपिक अल्ट्रासाउंड. याद रखना, ट्यूमर एंड नोडल स्टेजिंग मतलब बस ट्यूमर देखना है कितना डीप है वॉल में, और दूसरा लिम्फ नोड्स देखने कितने इन्वॉल्व है. इसके लिए esophageal और गैस्ट्रिक कैंसर में द इन्वेस्टिगेशन ऑफ चॉइस इज एन एंडोस्कोपिक अल्ट्रासाउंड, बट कोलोरेक्टल कैंसर के लिए इट इज अ MRI. इफ दे आस्क यू इन्वेस्टिगेशन ऑफ चॉइस फॉर ओवरऑल स्टेजिंग, व्हेन वी से ओवरऑल स्टेजिंग दैट इज TNM staging, मतलब distant metastasis भी जब देखना है, then the investigation of choice is a whole body scan called as PET CT. Reason is PET is a functional scan, CT is an anatomical scan. दोनों combine करके best investigation हो जाते हैं for overall staging. If they ask you most common site of distant metastasis from colorectal cancer, हमें पता है all the GIT cancers mainly spread to the liver, whether it is esophageal, gastric or colorectal cancer, mainly metastasize to the liver. Treatment of choice in colorectal cancer is going to be various types of colectomy beta. Now, if I say patient is having a cancer in cecum, treatment is right hemicolectomy. If the patient is having a cancer in the ascending colon or the transverse colon, extended right hemicolectomy. That is, remove right colon, along with that remove the transverse colon also. If the cancer is in the descending colon, left hemicolectomy beta, remove the left half of the colon. If the cancer is in the sigmoid colon, we have to remove the sigmoid colon, that is called as sigmoidectomy beta, that is important. Or we can also remove sigmoid plus rectum together, that is called as low anterior resection. So when you remove sigmoid plus rectum together, that is called as a low anterior resection beta. That is what is important to be remembered. Clear about? Chalo. Now important is if I talk about the colon cancer bolana, I'll just add up something about the other two. The important things about the esophageal cancer beta if I talk about. We know. Please tell me what is the most common type of esophageal cancer beta? Squamous or adeno? We know the more common type of esophageal cancer is always a squamous cell carcinoma beta, and most common site for a squamous cell carcinoma is the most common site is going to be the middle third beta in squamous cell carcinoma. And adeno के लिए lower one third or lower third beta. Clear? So middle one third is the most common site for esophageal cancer, or to be specific for the squamous cell carcinoma, whereas lower one third is the most common site for an adenocarcinoma. Squamous cell carcinoma happens due to which condition mainly? See, smoking and alcohol are sarkari risk factors. They are always present. Specific risk factor will be, हमें पता है that achalasia cardia is a risk factor associated with squamous cell carcinoma, but adenocarcinoma is mainly due to GERD or Barrett's esophagus. We know in a patient who is having a long-standing GERD beta, patient develops a Barrett's esophagus, जिसमें the squamous epithelium changes into columnar epithelium, and there will be a special presence of goblet cells beta. That is important. That is called as Barrett's esophagus. Okay. Now important is in esophageal cancer beta, sorry, the patient will have the main complaint, and that complaint is nothing else but dysphagia. Continuous or intermittent? Continuous. Rather, it will be progressive in nature beta. And dysphagia more to solids or liquids? Here, the dysphagia will be more to solids as compared to liquids. This will help in differentiating achalasia cardia. Apart from that, patient will have weight loss and the other features as usual beta. Important in a case of esophageal cancer, what is going to be the investigation of choice? Upper GI endoscopy with biopsy. So upper GI endoscopy with biopsy is the investigation of choice beta. And for tumor and nodal staging, the investigation of choice will be endoscopic ultrasound. So endoscopic ultrasound will be the investigation of choice for tumor and nodal staging. Why? Because beta, we know the tumor staging in GIT cancers is done by, or it is based upon which parameter? The tumor staging in cases of GIT cancers is based upon depth of invasion, how deep the cancer is inside the wall beta. That is important to be remembered. Now, if they ask you in patients of esophageal cancer beta, treatment will be what? Treatment will be removal of the esophagus. That is known as esophagectomy beta. And we know that esophagectomy ki agar main baat karu, so please remember here proximal margin should be 10 centimeters and distal margin should be 5 centimeters. So esophagectomy with or without lymph node dissection will be done. Most common and the best type of esophagectomy performed is MCQs. तो हमें पता है that middle one third is the most common side beta, and I have told you middle one third में IVL revise करते हैं, but for the upper two third मतलब upper one third and lower one third दोनों sorry upper one third and middle one third दोनों के लिए the best surgery is always MCQs. ठीक है, तो MCQs surgery is the most common type of esophagectomy that we are going to perform beta. No issues with this. And some points about gastric cancer I also add over here. If I talk about gastric cancer beta, so we know it is adeno or squamous. Gastric cancer is always an adenocarcinoma beta because stomach is lined by columnar epithelium. So gastric adenocarcinoma associated with which gene mutation? So we know that gastric cancer is very commonly associated with E-cadherin gene mutation. Which variety? The intestinal or the diffuse variety? The diffuse variety is associated with E-cadherin gene mutation, whereas intestinal one is associated with APC gene mutation. APC gene mutation. Next important, another gene mutations. Yes, obviously it could be P53, APC, all of that. Important, E-cadherin gene mutation is also associated with which breast cancer? Invasive lobular carcinoma. So E-cadherin gene mutation is associated with gastric adenocarcinoma and invasive lobular carcinoma of breast. That is important. अब अगर मैं gastric adenocarcinoma की बात करता हूँ बेटा, in this patient again postprandial fullness, abdominal pain, weight loss, all these symptoms are going to be present. Gastric adenocarcinoma is the most common cause of what? Gastric outlet obstruction. Previous year question of FMG exam. that most common cause of gastric outlet obstruction overall? Answer has to be gastric cancer. Why? Because the most common site for a gastric carcinoma is which part of the stomach? Antrum. The most common site for gastric cancer is the antrum, beta. That's the reason we know that most common cause of gastric outlet obstruction overall is gastric cancer. Most common cause of gastric outlet obstruction in neonates is CHPS. Neonates में अगर gastric outlet obstruction का most common cause पूछे तो answer has to be CHPS or hypertrophic pyloric stenosis. Important is gastric cancer is more commonly seen in which country? Japan. Reason being preservative rich food, beta. So preservative rich food is the main risk factor for gastric adenocarcinoma. Therefore, it is very commonly seen in Japan. Investigation of choice will remain same. That is upper GI endoscopy with biopsy, beta. Tumor and nodal staging again same. That is endoscopic ultrasound itself. And overall staging again same. That is PET CT. Now important is in patients of gastric cancer treatment की अगर मैं बात करूं, obviously treatment has to be a removal of stomach, that is gastrectomy. Okay, plus minus lymph node dissection. Important in gastrectomy, if I talk about beta, for example, if the cancer is in the distal part of the stomach, like antrum or pylorus, we should go for a partial gastrectomy or a total gastrectomy. तो अगर कैंसर डिस्टल पार्ट ऑफ द स्टमक में है, ओनली गो फॉर अ पार्शियल गैस्ट्रेक्टमी, बेटा. ओके, बट इफ द कैंसर इज इन द प्रॉक्सिमल पार्ट ऑफ स्टमक, जैसे कि बॉडी और फंडस, दैट इज कार्डिया, देन वी हैव टू गो फॉर अ टोटल गैस्ट्रेक्टमी, बेटा, क्योंकि एनास्टोमोसिस पॉसिबल नहीं होता अदरवाइज. ठीक है, तो इफ द कैंसर इज इन द प्रॉक्सिमल पार्ट ऑफ स्टमक, गो फॉर अ टोटल गैस्ट्रेक्टमी एंड देन गो फॉर अ ईसोफेगो जेजुनोस्टोमी. क्लियर? If I talk about definitely beta a gastric cancer, more important in gastric cancer is to know about the metastasis. Please tell me metastasis of a gastric cancer beta to the left supraclavicular lymph node is called as. एकदम एग्जैक्ट मैं तुम्हारी बुक की सीक्वेंस क्यों फॉलो करूंगा बताऊं? ठीक है, तो प्लीज रिमेंबर डेफिनेटली the metastasis to the left supraclavicular lymph node beta is known as Virchow's node, also called as which sign? Troisier or Trizier? Troisier sign, beta. Okay, it is also called as the Troisier sign. Next, if they ask you metastasis to the periumbilical region, so we know agar metastasis is seen in the periumbilical region, beta, then it is a classical case of Sister Mary Joseph nodules. It is classically known as Sister Mary Joseph nodules, beta. And lastly, if there is metastasis to bilateral ovaries, very good. You might have discussed in gynae also that metastasis to bilateral ovaries from a gastric cancer is a classical case of Krukenberg tumor. We know Krukenberg tumor happens due to spread of gastric cancer, especially diffuse gastric cancer, to both the ovaries via transcoelomic spread. Important. मुझे ये बताओ कौन से cells दिखेंगे हिस्टोपैथ पे? Very good. We know histopathological examination of Krukenberg tumor will show you classical signet ring cells. हमें पता है signet ring cells are only seen in gastric cancer. If they are seen in ovarian tumor, that means it is a case of an ovarian metastasis. कोई दिक्कत? So these are the important things. अब gastric cancer होगा almost 1.5 पन्ने का, but you have to remember it in these 7 to 8 points. This is how you narrow it down. तो जब सेकेंड रिवीजन थर्ड रिवीजन करते हो ये पॉइंट्स पे ध्यान दो, आगे बढ़ो. Okay, so that is how you have to focus. Next, coming back, beta, let's talk about anal cancer now. If I talk about anal cancer in a patient, beta, it is squamous or adeno? तो हमें पता है बेटा that 3 sites in the GI tract where squamous cell carcinoma is more common. One is oral cavity, second is esophagus, and third is anal canal. So oral cavity, esophagus, anal canal, these are the only 3 sites in the GI tract where squamous cell carcinoma is more common, beta. If they ask you in anal cancer which infection is associated, we know anal cancer or anogenital cancer is very commonly associated with infection called as HPV, human papilloma virus. Which strains? So we know that HPV 16 and 18 is commonly associated with cancer, whereas HPV 6 and 11 are commonly associated with anogenital warts, also called as condyloma lata या acuminata. condyloma acuminata beta. That is important. 6 and 11. If they ask you treatment, तो anal cancer के लिए treatment is वेरी गुड कीमो रेडिएशन बेटा. इट इज नॉट अ सर्जरी. रीजन हमें पता है कि एनल कैंसर में अगर सर्जरी करोगे तो 100% केसेस में द एनल स्पिंक्टर्स विल गेट डैमेज्ड. तो इसीलिए द बेटर ट्रीटमेंट इज ऑलवेज अ कीमो रेडिएशन बेटा. एंड दैट कीमो रेडिएशन इज गिवन अकॉर्डिंग टू विच रेजिम? निग्रोज रेजिम बेटा. तो निग्रोज रेजिम इज फॉलोड फॉर कीमो रेडिएशन इन एनल कैंसर. बोथ ऑफ देम आर पीवाईक्यूज. याद रखना है बात. कीमो रेडिएशन फॉलोड बाय द निग्रोज रेजिम. क्लियर है बात? तो याद रखना. एटलीस्ट रिमेंबर कीमो रेडिएशन 3 कैंसर्स के लिए याद रख लो. चलो तो फर्स्ट वन एनल कैंसर, सेकेंड वन इन नेजोफैरिंजल कार्सिनोमा, एंड थर्ड वन इंपॉर्टेंट बेटा इज सर्वाइकल कैंसर्स इन द लेटर स्टेजेस. ठीक है. तो 3 कैंसर्स के लिए याद रखना कीमो रेडिएशन देते हैं. एनल कैंसर ऑल द केसेस. नेक्स्ट इंपॉर्टेंट इज गोइंग टू बी अ नेजोफैरिंजल कार्सिनोमा एंड इन एडवांस स्टेजेस ऑफ सर्वाइकल कैंसर. Now, if I talk about this condition, a long distance truck driver complains of perianal pain and a pus discharge from these openings which are present in the natal cleft or in the perianal region. This is a classical diagnosis of pilonidal sinus. Pilonidal sinus definitely beta is one way or two way opening. It is only a one way opening with skin beta. That is important. ठीक है. तो pilonidal sinus. यहाँ पे क्या होता है? पहले initially the patient develops abscess, then that abscess ruptures and that leads to formation of a sinus. The main reason is prolonged sitting in the patient beta. ठीक है. Patient will complain of pain and pus discharge. The pus discharge will be only from the opening or even from the rectum. Very good. In pilonidal sinus, the pus discharge is only from the opening. If the discharge is from the opening as well as from the rectum, then it is a case of perianal fistula. Very good. Next important, if they ask you, in cases of pilonidal sinus, what is the investigation of choice? MRI. For all the perineal structures, the best radiological investigation is always a MRI. So MRI is the investigation of choice. If they ask you, beta, that what is going to be the treatment in patients of pilonidal sinus? The treatment of choice is going to be the Bascom surgery beta, where we do excision of the sinus. So Bascom surgery, or which flap can be used? Very good. A rhomboid, also known as the Limburg flap beta. So rhomboid, also known as the Limburg flap, can also be used as a treatment for pilonidal sinus surgery. Pilonidal sinus beta. What is this case? Very good. So here you can see beta, the rectal mucosa is hanging outside the anal opening, and whenever the rectum hangs outside the anal opening, it is a classical diagnosis of rectal prolapse. हमें पता है rectal prolapse happens whenever the perineal muscles of the patient will become weak. ठीक है. The risk factors will be repeated episodes of diarrhea or obstructed labor in females. Now, there are two types of rectal prolapse that we have beta, either a partial thickness or a full thickness rectal prolapse. Partial thickness rectal prolapse में which layer hangs out? Only mucosa beta. ठीक है. Usually only mucosa hangs out. So please remember, in case of partial thickness rectal prolapse, it is mainly the mucosa hangs out, whereas in full thickness rectal prolapse, all the layers, mucosa, submucosa, muscularis, all the layers hang out in full thickness rectal prolapse. Partial thickness rectal prolapse is common in which age group? Partial thickness rectal prolapse is common in children, whereas full thickness is common in adults, especially elderly patients beta. Adults, especially elderly patients. Now important is if they ask you what is the treatment. So here definitely beta, in cases of partial thickness rectal prolapse, if the child has been brought to you with a very first episode, then the treatment is वेरी गुड. तो प्लीज रिमेंबर बेटा, फर्स्ट टाइम अगर बच्चा तुम्हारे पास आया तो मैनुअल रिडक्शन कर दो, दैट इज डिजिटल रीपोजिशनिंग कर दो बेटा. तो फर्स्ट टाइम अगर है पार्शियल थिकनेस तो गो फॉर ओनली अ डिजिटल रीपोजिशनिंग और अ मैनुअल रिडक्शन. बट इफ इट इज अ रिकरेंट केस ऑफ अ पार्शियल थिकनेस रेक्टल प्रोलैप्स, तो रिकरेंट केस ऑफ पार्शियल थिकनेस रेक्टल प्रोलैप्स में वी हैव टू गो फॉर अ थियर्स wiring, where we try to narrow down the anal canal beta or the anal opening by applying which kind of suture? वायर पास कर सकते हो या सूचर कौन सा? purse string suture. So around the anal opening, you are going to apply a purse string suture, which will narrow down the anal opening so that the rectum cannot come outside beta. That is what is done. Next important, if I talk about full thickness rectal prolapse, here we can either go for perineal surgeries or abdominal surgeries. Which one will have less chance of recurrence? Abdominal surgeries mein proper fixation is done, so they have less chance of recurrence, but they are associated with a lot of complications beta. Perineal surgery on the other hand will definitely be less complex beta, but they will have high chance of recurrence bache. Elderly patient may we prefer perineal surgery because we don't want any complication. Young patients may we prefer abdominal surgery because we don't want any recurrence. ठीक है? Important है perineal surgeries के नाम बताओ. Perineal surgeries के नाम. One is Thier-Schweiring, second is Altemeyer's repair, and third is Delorme's repair. ठीक है? तो याद रखना Altemeyer's repair or Delorme's repair, which is there beta, these are the perineal surgeries that we perform. But अगर abdominal surgeries की बात करें, तो definitely either it is the Wells or second is the Ripstein's rectopexy commonly beta. Goldberg is also done, but commonly the ones that we do is either a Wells repair or a Ripstein's repair beta. That is rectopexy surgery. Hopefully cleared all of you now. तो याद रखना, तो perineal surgeries, Altemeyer's, Delorme's और Thier-Schweiring ये होता है. Abdominal surgeries, Wells और Ripstein's rectopexy होता है. That is what is important to be remembered. क्या होता है? If I have been asked, I would do that. I have not been informed, I have not been asked beta. अपने मन से तो नहीं होता. So that is what is important basically. Okay. Next important if I talk about now. The next क्या? GIT तो खत्म करो, break. Now important is if I talk about hemorrhoids beta. GIT हो गया खत्म, अभी एनल कैनाल है. अरे GIT बोल रहा हूँ मैं, पैनक्रेटिको हेपेटोबिलियरी नहीं बोल रहा मैं. Hemorrhoids, if I talk about beta, hemorrhoids is also known as piles, basically, bawasir. Now, hemorrhoids or piles में beta, the अब क्या? हाँ बवासीर ही बोलो फिर, कोई दिक्कत नहीं. तो hemorrhoids, if I talk about definitely beta, it is when the rectal vessels are going to get dilated and tortuous beta. तो क्या हो जाएगा? These rectal vessels may rupture, okay, and then can cause a bleeding per rectum. Please tell me beta, what is the main risk factor responsible for hemorrhoids? We know the patient will always give you a prolonged history of constipation. That is the main risk factor responsible. And what is the main presenting complaint of the patient? Painless or painful bleeding per rectum. We know majority hemorrhoids are internal hemorrhoids beta, and that is the reason the patient will have a painless bleeding per rectum beta. Okay, the patient will have a painless bleeding per rectum, definitely that has to be kept in mind. ठीक है, तो प्लीज रिमेंबर कॉन्स्टिपेशन डेफिनेटली बेटा, एंड सेकंड पेनलेस ब्लीडिंग पर रेक्टम विल बी द प्रेजेंटेशन इन अ केस ऑफ हेमोरॉइड्स बेटा. पेनफुल ब्लीडिंग पर रेक्टम बेसिकली इज ओनली सीन इन विच टाइप ऑफ हेमोरॉइड्स? अरे external hemorrhoids and thrombosed hemorrhoids. तो याद रखना majority hemorrhoids are always painless, but external hemorrhoids and thrombosed hemorrhoids will be painful beta. That is important. अगर वो पूछते हैं primary hemorrhoids will be located in which position? If you consider anal canal as a clock, then 3, 7, and 11 o'clock position pe, you will find a primary hemorrhoid. Anywhere else, it will be considered as secondary hemorrhoids itself, beta. That is important. Ab agar wo puchte in patients of hemorrhoids, beta, what is going to be the investigation of choice? We know that no radiological investigation is required. Only a proctoscopy is considered as the investigation of choice in patients of hemorrhoids. That proctoscopy will tell you about the dilated vascular mass, which can bleed and can cause bleeding per rectum. Now, if they ask you about treatment beta, so first degree hemorrhoids, we know there are how many grades of hemorrhoids? There are 4 degrees or 4 grades of hemorrhoid. Now, grade 1 there is only bleeding but no prolapse beta. ठीक है, मतलब कोई मास बाहर नहीं आता. तो फर्स्ट डिग्री में देयर इज ओनली ब्लीडिंग, नो प्रोलैप्स. ग्रेड 2 में और सेकंड डिग्री में बेटा, हियर मास कम्स आउट ऑन स्ट्रेनिंग बेटा, but it shows a spontaneous reduction. तो if second degree बोलेंगे जब mass is going to show us a spontaneous reduction बेटा. Grade 3 में और third degree में again the mass comes out on straining, but this time it needs to be manually reduced बेटा. तो grade 3 और third degree में it require the mass needs a manual reduction, and fourth degree और fourth grade में बेटा the mass is always hanging outside but it cannot be reduced beta. So when mass is always hanging outside but cannot be reduced, it is fourth degree or grade 4 hemorrhoids. Understood? Now important is first degree hemorrhoids mein treatment bolo. Very good. First degree hemorrhoids mein treatment is only and only lifestyle modifications beta, and lifestyle modification should be to avoid constipation in the patient. That is plenty of fluids, high fiber diet, avoid fried fatty food and meat. Apart from that, baki stool softeners can also be given if required. Second degree hemorrhoids. Second degree hemorrhoids mein we have to go for banding. Either you can call it as band ligation or you can call it as banding. Another alternative will be sclerotherapy, which will cause fibrosis and it will stop the bleeding. So second degree or grade 2 hemorrhoids mein banding is a better procedure. If that's not if that cannot be done, then go for sclerotherapy beta. Next, third and fourth degree hemorrhoids may we always need a surgery beta. So third and fourth degree hemorrhoids is always operated beta, and the surgery of choice nowadays is stapler hemorrhoidopexy beta. The surgery of choice for third and fourth degree hemorrhoids is hemorrhoidopexy because it causes lesser bleeding. But if there is a case of recurrence, then the better surgery is hemorrhoidectomy. If there is a recurrence beta, then we have to go for a hemorrhoidectomy. Hopefully understood, bache. That is what is important. Now, important is if I talk about the next condition, and that is nothing else but anal fissure beta. Now, anal fissure is nothing else but a cut or a crack inside the anal epithelium. Here also the most important risk factor will be constipation, which will cause hard stools beta. So hard stools basically during constipation is the main reason for anal fissure to develop. Patient presents to you with painful or painless bleeding. Here the patient will have an extremely painful bleeding per rectum beta. Here the patient will have extremely painful bleeding per rectum. That has to be kept in mind beta. The extremely painful bleeding per rectum is going to be present. Investigation of choice. Very good. Investigation of choice for anal fissure is nothing else but an external inspection. Will you go for a DRE or a proctoscopy? No. It is absolutely contraindicated due to pain. Otherwise, क्या होगा? Shabash. Treatment, if I talk about beta, treatment will be mostly conservative or surgical. Conservative beta. Surgery is dangerous over here. It can have a problem of anal or a fecal incontinence beta. So इसीलिए treatment is majorly conservative, जिसमें again you will advise the same lifestyle modifications beta, like plenty of fluids, take a high fiber diet. Here important advice will be a sits bath beta. So sits bath, that is take warm water tub and sit inside that beta. It will give you pain relief. Second important, you can also give some analgesics for local application like a 2% xylocaine jelly. अगर कुछ नहीं काम करता तो we go for a surgery, and that is a lateral anal sphincterotomy. But the problem with lateral anal sphincterotomy surgery is we will cut the sphincters, and अगर गलती से भी by mistake also the cuts are too deep, the sphincters will never contract again in life, causing a fecal or anal incontinence beta. Next, if the patient is having a pus discharge per rectum, it is a diagnosis of perianal fistula. तो अगर pus discharge per rectum होता है बेटा along with a lot of pain, the diagnosis of the patient is a perianal fistula. जहाँ पे patient will initially develop a perianal abscess, and then that perianal abscess is going to rupture, and that will lead to formation of a perianal fistula. If I talk about perianal fistula, which is the most common type? According to Park's classification, the most common type of perianal fistula, according to the Park's classification, is an intersphincteric fistula. Matlab, that fistula which opens between the two sphincters beta. यहाँ पे देख सकते हो this fistula over here. This is an intersphincteric fistula, which is the most common type of fistula beta. Next important, if I talk about bache, in a case of a perianal fistula, what is going to be the investigation of choice? So investigation of choice in patients of perianal fistula, answer is going to be a MR fistulogram. So MR fistulogram is going to be the investigation of choice beta. MR fistulogram is which type of MRI done for fistula? It is a T2 weighted MRI done for the fistula beta. That is important. अब अगर मैं बोलूं कि which rule is followed in perianal fistula? Good-Saul's rule is followed definitely beta. So we know that the Good-Saul's rule is followed for perianal fistula, which says the anterior fistulas will always have straight track or a curved track. Anterior fistulas will always have a straight track, but posterior fistulas will always have a curved track beta. So Good-Saul's rule के according, anterior fistulas have a straight track, posterior fistulas have a curved track. But it is only applicable for those anterior fistulas which lie between the 11 o'clock to 1 o'clock position. तो 11 o'clock to 1 o'clock बस इतने fistulas के लिए वो rule applicable है. बाकी पूरे के पूरे posteriorly open होता है, बाकी पूरा का curved track होता है. If they ask you about the treatment beta, if it is a high perianal fistula which opens above the anorectal ring, treatment is set on thread beta. तो अगर high perianal fistula है तो we will insert a set on thread inside the fistula beta, that is the treatment. But अगर low perianal fistula है तो there are two options beta, either cut open the fistula tract known as fistulotomy or definitely remove the fistula completely, that is fistulectomy. याद रखना, हाई पेरियानल फिस्टुला के लिए ट्रीटमेंट इज सेट ऑन थ्रेड इंसर्शन. लो पेरियानल फिस्टुला के लिए ईदर ओपन अप द फिस्टुला एंड ड्रेन इट कॉल्ड एज फिस्टुलोटोमी या बेटर एक्साइज इट कंप्लीटली, दैट इज फिस्टुलेक्टोमी बेटा. आंसर दिस क्वेश्चन ओवर हियर. What is the most appropriate next line in management of the patient? What is the most appropriate next line in management of the condition in the given radiograph of a male newborn? What will be your answer? Very good. Answer would be option D, that is MRI. What is the likely diagnosis? Very good. Here, definitely, what is the investigation shown over here? Invertogram. So here, the classical diagnosis is of a ARM, that is an anorectal malformation. Which ARM it is? Which ARM? Imperforate anus. The ARM that is present over here, it is an imperforate anus. You can see the anal opening has not formed properly. There is a gap between the metallic marker and the gas shadow beta. मतलब इतना हिस्सा नहीं बना हुआ. So it is a case of an imperforate anus basically. And we know imperforate anus अगर है या कोई भी anorectal malformation है, the first line investigation that we perform is a invertogram. When the baby is held upside down beta and we do a X-ray of those babies definitely. That is known as the invertogram. This is a first line investigation. But what is the investigation of choice? Investigation of choice for all the all the perineal problems is a MRI. तो इन्वेस्टिगेशन ऑफ चॉइस MRI. तो यहाँ पे उन्होंने पूछा है नेक्स्ट लाइन इन मैनेजमेंट. मैंने हमेशा बोला है मैनेजमेंट मींस डूइंग अ प्रॉपर डायग्नोसिस एंड देन ट्रीटिंग द पेशेंट. तो मैनेजिंग द पेशेंट को मैनेजमेंट बोलते हैं. ठीक है, तो यहाँ पे MRI करोगे और उसके बाद ट्रीटमेंट ऑफ चॉइस क्या है? एनोरेक्टोप्लास्टी विथ और विदाउट कोलोस्टोमी. अगर हाई ARM है तो कोलोस्टोमी की जरूरत पड़ती है. अगर लो ARM है तो देन वी डोंट नीड एनी कोलोस्टोमी फॉर दैट केस बेटा. ठीक है, तो PSARP, that is posterior sagittal anorectoplasty with or without colostomy. Understood? Last part and then you can take your break, and that is appendix. That is the last part of GI tract. That is appendix, vermiform appendix. We know it is a blind tubular structure present at the ileocecal junction or the ileocolic junction, supplied by the branch of ileocolic artery known as appendicular artery. Most common position of appendix is retrocecal, followed by second most common position is pelvic. Least common position is post ileal beta. Least common position is going to be post ileal. If they ask you what is the main problem in appendix, it is nothing else but acute appendicitis. Acute appendicitis is more commonly seen in which age group? We know acute appendicitis is more commonly seen in adolescents and young adults, that is 10 to 25 years of age group. So 10 to 25 years of age group is the commonest age group for acute appendicitis. Okay, and please tell me, If the patient develops an obstructive appendicitis, then what is the most common cause of an obstructive appendicitis? Very good. तो अगर obstructive appendicitis develop होता है बेटा, तो the most common cause of an obstructive appendicitis is a fecalith. In a patient of chronic constipation, there is a hard stool that will form a fecalith, and that fecalith is known to cause an obstructive appendicitis commonly. अगर वो बोलते हैं whenever a patient of acute appendicitis comes to you बेटा, obviously if you're suspecting a case of appendicitis, कैसे पता लगाना है? By the signs, symptoms and the lab findings of the patient, that whether the patient is having chances of acute appendicitis or not. Very good. We know we are going to assess the patient's Mantel score, also called as the Alvarado score. To check for the patient's Alvarado or the Mantel score of the patient, and depending on that score beta, you can suspect whether your patient is having a chance of acute appendicitis or not. Ab Mantel's is an abbreviation beta in itself for all the 8 parameters. M stands for migration of pain to the right lower quadrant or migratory right iliac fossa pain. From where does the pain migrate? Umbilicus region. Why? Because the umbilicus and the right iliac fossa, both of them are usually supplied by the same dermatome, that is T10. So the migratory right iliac fossa pain in patients of acute appendicitis is due to the T10 dermatome, that is given a score of 1. A stands for anorexia, that is loss of appetite, given a score of 1. N stands for nausea and vomiting, given a score of 1. T stands for tenderness in the right iliac fossa, given a score of 2. Next, R stands for rebound tenderness, also known as which sign? Blumberg sign. Rebound tenderness ka matlab, when you palpate, there is no pain. But when you release, now the patient experiences pain. That is called as rebound tenderness or Blumberg sign, given a score of 1. E stands for elevated temperature, that is fever, given a score of 1. L stands for leukocytosis. Leukocytosis or increased leukocyte count, given a score of 2. And S stands for shift to left beta. So shift to left matlab more amount of mature or immature neutrophils. More amount of immature neutrophils is called as shift to left. That is given a score of 1. Total score is 10. If the patient score is less than 5, that is suggestive. Appendicitis is unlikely beta. So yaad rakhna, if the score is less than 5, that means appendicitis is unlikely. You can discharge. If the score is 5 or 6, that means appendicitis is possible or 50-50% chance. That is called as equivocal, and this is the most dangerous score. Therefore, you send the patient for CECT abdomen beta to rule out acute appendicitis. If the score is going to be 7 or 8, appendicitis is likely. And if the score is 9 or 10, appendicitis is high likely or almost certain. It is almost certain diagnosis of acute appendicitis. Investigation of choice to further confirm it. Adults में CECT abdomen, children में the same rule follows. ठीक है? तो adults के लिए the investigation of choice is a CECT abdomen, children के लिए the investigation of choice is an ultrasound abdomen, which will confirm your diagnosis. If you want to clinically elicit few signs beta, you can. First condition, if you definitely palpate the left iliac fossa and that causes a pain in the right iliac fossa, it is known as Rove-Singh sign beta. तो याद रखना, Rove-Singh sign का मतलब लेफ्ट साइड palpate करने पे राइट साइड में दर्द होता है. That is the Rove-Singh sign. Next important, rebound tenderness. Blumberg sign beta. The Blumberg sign is known as rebound tenderness. Pain on cuffing. Dumfries sign beta. Pain on cuffing is classically known as the Dumfries sign. Next, if I go for hyperextension of hip, that causes pain. सोवास साइन. वेरी गुड. अगर तुम राइट हिप को हाइपर एक्सटेंड करते हो तो पेशेंट में पेन होता है बेटा, एंड दैट इज क्लासिकली कॉल्ड एज अ सोवास साइन. सोवास साइन इज पॉजिटिव एंड द लोकेशन ऑफ अपेंडिक्स इज रेट्रोसीकल. वेरी गुड. तो जब अपेंडिक्स रेट्रोसीकल प्रेजेंट होगा तो सोवास साइन पॉजिटिव होती है. नेक्स्ट, इंटरनल रोटेशन ऑफ राइट हिप कॉजेस पेन. ऑप्टेरेटर साइड. जब राइट हिप को इंटरनली रोटेट करोगे तब दर्द अगर होगा तो दैट इज ऑप्टेरेटर साइन. इट इज पॉजिटिव व्हेन द लोकेशन ऑफ अपेंडिक्स इज pelvic. तो जब अपेंडिक्स का लोकेशन pelvic होता है then the obturator sign is positive beta. Management of acute appendicitis will be always surgery, and that surgery is removal known as appendectomy. तो appendectomy or appendectomy is the surgery of choice or treatment of choice for acute appendicitis. Either it can be a open or a laparoscopic appendectomy. Open appendectomy अगर करना है तो the incisions that I can use is one in the right iliac fossa beta. In the right iliac fossa, oblique incision is known as McBurney's incision. In right iliac fossa, the oblique incision is known as McBurney's incision, or the transverse incision is known as Lanz or the bikini incision beta. Clear है बात? तो McBurney's is an oblique incision, Lanz is a transverse incision beta. That is what is important to be remembered. Okay, now answer this question. Another previous year question of FMG exam. Pregnant female presents to the emergency with acute appendicitis. Options for management. Conservative management, Oshner-Sharon regime, emergency appendectomy, elective appendectomy. Answer will be emergency appendectomy beta. Reason we know pregnancy is an immunocompromised state. So the risk of appendicular perforation is very, very high. And due to that, the treatment is always an emergency appendectomy beta. So as the risk of perforation, we should always go for an emergency appendectomy during pregnancy. Clear है बात? That has to be kept in mind beta. Answer this question. 16-year-old male beta presents to the surgery emergency with complaints of sudden onset right iliac fossa pain beta along with fever and anorexia. You suspect that the patient is having appendicitis. For assessment, we use the modified Alvarado score, which reveals a score of 9. That means the diagnosis of acute appendicitis is almost certain. The patient refuses the treatment but has been brought to the emergency department again after a span of 3 days. On palpation, it reveals a lump inside the right iliac fossa. Which among the following is the most appropriate management? Diagnosis is very good. So yaad rakhna, the diagnosis of this case is not an acute appendicitis anymore. Now it has progressed into a complication known as appendicular lump. हमें पता है due to acute appendicitis, the bowel becomes very sticky or adherent beta. And as the bowel becomes very sticky or adherent, that is the reason why the omentum wraps around the appendix, leading to formation of an appendicular lump. और हमें पता है appendicular lump के लिए the treatment should not be a surgery or an appendectomy immediately. Reason, adhesions जब होता है तब if you try to definitely go for a surgery, there will be a very high risk of bowel injury beta. तो इसीलिए we go for a conservative management, that is keep the patient nil per oral, give IV fluids, IV antibiotics and analgesics beta, and continuously monitor the patient whether he improves or not. And this regime is classically known as Oshner-Sharon regime. So either conservative management will be there in the option or Oshner-Sharon regime will be there in option. याद रखना, मैंने पहले ही बोला था that in cases of acute appendicular lump, पहले 3 से 4 लाइन बेटा will always describe a case of acute appendicitis always. But याद रखना अगर उन्होंने एक word डाल दिया and that is lump, your answer changes from appendectomy to conservative management. Clear है बात? So that is important. Okay, this has been a previous year NEET PG and FMG question both. Repeated that too. Emergency appendectomy is usually done in cases like pregnancy or immunocompromised patients beta, where there is a risk of perforation. अगर Oshner-Sharon regime कर रहे हो, so you have to continuously monitor the patient. If the patient's condition improves, we will discharge the patient and call the patient back after 6 weeks for an interval appendectomy. But अगर patient की condition खराब हो जाती है, if the patient's condition worsens, then we will go for an extraperitoneal drainage. क्यों? क्योंकि अगर patient की condition खराब हो रही है, तो it is not a lump basically, it is a case of appendicular abscess. इसीलिए patient ठीक नहीं हो पा रहा. Clear? So that is what is important. Perforation अगर होगा तो क्या करोगे? Exploratory laparotomy बेटा. That is important. जाओ, pancreas start हो रहा है, जाओ, lunch break ले लो अपना.